Good morning, everyone. Welcome to our symposium today. It's titled Kidney Disease in the Genomic Era. I want to thank you for joining us on this Saturday morning. My name is Anjay Rastogi. I'm a nephrologist practicing at UCLA, and I will be moderating this symposium today. But before getting into the symposium, I do want to take a second to thank Natera, UCLA Core Kidney Program, the Circle of Core, and also our Brew and Beans Health Program for supporting and making this event happen. Now, I mentioned Circle of Core. That's our patient advocacy and support group, and a key member from that group will be speaking today and sharing her own experience. So that's is a very powerful story, and I really hope that you stay. It's going to be towards the end. So why are we here? And I think that's a question that I was asked yesterday. Why are we doing this symposium? So giving a bit of a background, 10% of kidney disease can be attributed to genetic causes. So 10% of them actually have a genetic cause. Now, why is that important? First of all, the management will depend upon the right diagnosis. So if you don't have the right diagnosis, you can't get the management. So getting the diagnosis correct is very, very important. The second part is, even if you don't have a disease-specific treatment, there are a lot of trials going on that these patients can participate in. But even more important than that, when you have a genetic cause, it affects not only the patient, but their families and generations to come. So this is a much more complex than a diagnosis that we give, like diabetic kidney disease or hypertension, to a patient. So looking at genetics is very, very important. Now, one of the questions we get asked is, as a person who does specialize in genetic causes, we started the Nephro-Genetics program at UCLA. When do we order this test? Who do we order on? Is it for patients with chronic kidney disease, acute kidney injury, patients who are on dialysis already, transplant? How about living donors, at-risk family members? And how do I order it? Even if you have identified patients that we think might benefit from genetic testing, how do we order these tests? And then what do we do with those results, right? And then downstream, how does it affect our management and at risk? So we have an expert faculty today that will be addressing all this and much more. And there will be a live Q&A session at the end. And if you have any questions, please put them in the chat box, and we'll do our best to answer all the questions. In case we are not able to answer them, we will get back to you afterwards. But I also want to put one more thing in perspective. So in kidney disease, I mentioned 10% or up to 10% have an identifiable genetic cause. Are there other conditions that have similar, numbers? And the answer is yes. If you look at cancer, they 10%, up to 10% have a genetic cause in cancer as well. And genetic testing is actually a part of the diagnostic workup. And the question then comes up, should genetic testing be a part of our kidney workup, diagnostic workup? And today, we hopefully will answer some of those questions. So with that, I will jump into our first presentation, and that is a primer, a genetic primer for the modern nephrologist. So it's a primer, a refresher for our nephrology colleagues and how they can use testing, diagnostic, and management in their patient population. So our first speaker and a dear friend of mine, Dr. Bianca Russell. So Dr. Bianca Russell is an assistant clinical professor in the Department of Pediatrics and the Division of Genetics at UCLA. She obtained her medical degree from UC Irvine and completed her combined pediatrics and human genetics residency and metabolic fellowship at Cincinnati Children's Hospital. Dr. Russell is a clinical geneticist with a particular interest in kidney conditions, including Fabry disease, polycystic kidney disease, kidney malformations, and other genetic kidney disorders. Dr. Bianca Russell, when she came to UCLA Health a few years ago, has changed, at least from my perspective, how we are managing genetic causes of kidney disease. She's also accompanied by her genetic counselor, Miss Marina Clark, another very, very amazing counselor, but also a key member of the UCLA Nephro-Genetics program. So a bit of history about Miss Clark. She's a genetic counselor, board certified by the American Board of Genetic Counseling and licensed in California. She received her master's degree in genetic counseling at University of California, Irvine, and received her bachelor's degree in biological sciences from Rutgers, the State University of New Jersey. Her role at UCLA is focusing on chromosome 22 mutations, hearing loss, kidney genetics, and general pediatrics. She is a member of the UCLA Clinical Genomics Center, where she assists in variant interpretation for exome and whole genome sequencing tests in both clinical and research settings. Marina is also a clinical supervisor and lecturer for the UCLA Genetic Counseling Master's Program. So with that, it's really my privilege and honor to welcome Dr. Russell and Ms. Clark for their portion on primers. Thank you.
Thank you for the introduction. So I'm Marina Dutra-Clark. I'm a genetic counselor at UCLA. And how we're gonna set up this talk is I will start by giving you an overview of genetics, and then I'll hand it off to Dr. Bianca Russell, who's a clinical geneticist, and she'll share some really interesting cases, and you'll see how we've applied a lot of these genetics principles. And our talk is called The Genetics Primer for the Modern Nephrologist. And this talk was supported by Natera. So we know that genetics plays a role in nearly all aspects of medicine, but a particularly strong role in kidney diseases. And Dr. Rastogi just highlighted the many benefits of knowing the underlying genetic cause of the patient's kidney diseases. And so it's very important. I really want to emphasize that today. We've actually been in this genetic revolution or genomic era for quite some time now, though. We've sequenced the human genome 20 years ago, and next generation sequencing was developed 10 years ago now. So I think by now we really should be offering genetic testing routinely for these patients. And you've probably noticed how fast-paced the genetics field is. There are tens of thousands of genetic tests on the market, and with more options, it can be more confusing in selecting the right test for your patient. You've probably noticed that the list of genes on panels can vary between commercial labs. The test methodologies can vary between labs. So if possible, collaborate with clinical geneticists and genetic counselors to help select the appropriate test for your patient and for the right price for your patient. So after the sample's at the lab, how do they analyze the sequence data? Well, the lab is looking at your patient's variants, which are the sequence changes in the genetic code, and they're taking those variants and comparing them to the variants in our large data sets of other people in the general population data sets. So, and looking to see what is different in your patient. The problem with this is that there are millions of variants that differ between one individual and another. So human variation is normal. So it's very difficult to decide whether a variant is benign or a disease-causing variant. Most labs use this 5-point scale that indicates the likelihood that the variant is disease-causing. It ranges from benign to likely benign to variant of uncertain significance, or VUS, likely pathogenic, and pathogenic. And then I listed out some of the common tools and criteria that's used in variant interpretation and classification. So for example, population databases are key. Like if the gene is typically associated with a severe kidney disease and it's highly penetrant, then we would not expect that variant to be commonly seen in our population database. Also, is it the right variant for that gene? So for example, some kidney diseases are exclusively caused by a particular variant in a particular domain of that gene. So is it the right mechanism? And then has it been reported in the literature before? Has that variant been seen before? Is there co-segregation data? So often we'll order genetic testing for other family members and see, is that variant tracking with the disease in that family? And also, does the clinical and family history fit with your patient? Sometimes phenotype is not part of the variant level interpretation. So definitely use your clinical judgment and always send in your clinic notes to the lab. And what about the in silico prediction tools? What do they say? Those are the computer algorithms that can help predict the effect on protein function. And are there any in vitro or in vivo experiments for this particular variant? Because that would be very helpful too. And this is also why genetic test reports are 10 pages long sometimes, because they lay this all out for you, all the databases that they used and all the tools that they used. Hopefully in the future, our patients will have better access to orthogonal methods like RNA sequencing and proteomics, but for right now, you're pretty much working with this list. And something to really keep in mind is that some labs don't agree on a variance classification. So there is discordance. Even though they're all using similar guidelines, like standardized guidelines, there's still discordance. So here's an example. There was a study that came out last year where they took 8 labs, submitted variants and their classification, and nearly half of those variants had discordance between 2 or more labs. And 63% of the pathogenic and likely pathogenic variants were discordant with variant of uncertain significance by another lab. And 11% of the discordance cases would have impacted clinical recommendations. So here's a sample genetic test report that I want to walk you through. So starting from left to right, the gene is listed, a PKD1 gene. And the disease that it's associated with is polycystic kidney disease. And the inheritance is autosomal dominant. So we have 2 copies of all of our genes. And autosomal dominant inheritance is where there's a pathogenic variant in one of those gene copies. And then here in the variant column, that lists out the GPS coordinate of your variant. So here it's always given in 2 nomenclatures. So the top line is the cDNA nomenclature, and the bottom is what's happening on the protein level. So the cDNA, that's showing you which variant is changed. In this case, the variant was deleted. And then there was an effect on the protein. So we have the leucine is the first protein that's affected by this. And it's changed to a tryptophan. And in fact, this deletion of that one base pair caused a frame shift in the entire code. And it affected all of those amino acids, 93 amino acids further down, and then led to a premature stop. So FS stands for frame shift, and then the asterisk tells you that there was a stop. So this is a truncated protein product. And it's heterozygous, meaning they found that variant in about half of that sample, so consistent with that autosomal dominant inheritance. And the lab classified this variant as pathogenic, and they list out the rationale under the interpretation section. And I just outlined some key points in the interpretation section showing that it is the right type of variant, because as a frame shift truncating variant, that does fit with the mechanism for PKD1. And also it's been reported in the literature in unrelated individuals. So that's showing replication. And then lastly, the variant is absent from our Broad Nomad dataset. So this variant is rare and not seen in our healthy general population. So now I've just explained this to you. How do you explain this to the patient without using technical terms and technical jargon? So I would just, I would keep it simple. I would just say, our genes are the instructions for the body to function properly. And one of those genes is the PKD1 gene. And there was a typo found in that instruction. So the 11,554th letter was deleted in those instructions. And that caused the instructions to stop short. And this is called autosomal dominant polycystic kidney disease. So in addition to just giving the patient the genetic information, what else would be important and part of the genetic testing, genetic counseling process? Well, genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And genetic counselors really like to emphasize the part that says and adapt. So it's not just giving them the genetic information. We have to also help our patients adapt to this information. So work through your patient's emotions, address shame, guilt, fear, and misconceptions. There are some patients who don't realize that the age of onset or disease severity can vary even between members of the same family who have the same variant. Also, empower your patient. How can we increase your patient's perceived control? We can't change the fact that they have this genetic condition, but there are ways that we can help them with how they perceive the uncertainty of their risks, how they react to just having this genetic condition, and how they perceive the value of the medical treatment and interventions that are recommended thereafter. We provide medical and support resources. And of course, genetics is a family affair, so we discuss familial implications, like testing at-risk relatives, and we provide a family letter that they can use to distribute. And also for any family members who wish to be potential donors, we recommend genetic testing in them. And we counsel on the recurrence risk based on the inheritance pattern of the gene, and family planning options are discussed. For example, there is an option to not pass on the genetic condition to the offspring using in vitro fertilization and pre-implantation genetic testing. So with that, I'm going to pass it on to Dr. Bianca Russell. Thank you.
Great, thank you so much, Marina. So we're going to jump into some cases that are going to highlight some genetic principles. So we'll start off with polycystic kidney disease. This is a case of a 9-year-old male with left multicystic dysplastic kidney that was noted prenatally, and he has a solitary right renal cyst that was found at age 4. He is a di-di non-identical twin, and it was conceived by IVF with a sperm donor. So his genetic testing identified a mutation in PKD1, and this is the mutation that was identified. Interestingly, it is a truncating mutation, like Marina just described to you, a frame shift variant. But something a little bit different about this is that it's only present in 20 to 25% of the cells that were tested on this blood sample. So we call this mosaic, meaning that it doesn't affect every cell in the blood that was tested, but only about a fourth of it that showed this specific change. So we see this in about 1% of patients with ADPKD, and we think that as well there's about 10% of ADPKD that does not have an identifiable genetic cause but fits clinically. We think about 10% of those cases may in fact be mosaicism that's missed. And that's challenging because we do not look at every cell in the body. So when we take a sample of the blood, we're getting only a small piece of what's actually going on in the rest of the body. And it may be possible that there are changes in the genetic code located just in specific tissue types, such as the kidneys. So in this young boy's situation, it's quite possible that there is a higher mutation burden in one kidney over the other, hence the variability that you see with one kidney having prenatal onset and the other having more of a classic ADPKD presentation. When we see a mosaic pattern like this, it is expected to be de novo, and that this is a change that was caused after conception. So a couple notes about PKD1 as a gene. It's quite challenging. It's very large with 46 exons. It has a high GC content, which means that it's really difficult to sequence. There are 6 pseudogenes, so that are about 98% the same as the gene you're actually supposed to be looking at, and it's on the same chromosome. So as you can imagine, it's really challenging to sort out what is the pseudogene and what is the actual gene of interest. So it's really important to have full gene coverage, and you really do need specific sequencing tools and skilled interpretation in order to analyze variants in PKD1. And it is important to check whether or not the lab that you are using actually tests for this gene, as many labs do not include this gene on their gene panel due to the technical difficulty of interpreting and sequencing PKD1. Moving on to Fabry disease. So this is a case of a 34-year-old female. She reported GI dysfunction, fatigue, peripheral neuropathy, severe anxiety, depression, and progressive memory loss. There were no identifiable renal or cardiac conditions. And so here's just a picture of some of the systems that get impacted by Fabry disease, which is a lysosomal storage disorder with multi-organ system involvement. Her genetic testing identified a change in GLA, which is the codes for an enzyme that's important for breaking down waste products in the lysosomes. And this is the variant here that was reported in her. And if you look in the description of this variant, it's a little bit tricky, and there's a question of what this variant actually means. And they actually raised the question of whether or not this variant would be impacting clinical function based on how it affects the enzyme level and whether or not this could be a pseudodeficiency. So one of the tricks we have up our sleeve is to look at some functional studies, or in this case, metabolic studies, and look at how something like an enzyme is working in the body. So for this patient, we tested her enzyme level and found that, in fact, her enzyme level was low. But then we take it the next step to look at what would be building up as waste products in the cell or the substrate to see if there's a buildup, as you would expect with a storage disorder. And in this case, there is not. And so the number we look at is the lyso-GL3, and her number there is normal. So just as a picture of showing what's happening here, the blue cell there on the left is your typical unaffected individual. You're in the lysosome there, and there's this GL3 product that is broken down by an enzyme and then utilized within the cell. In somebody who has Fabry, you see that there's that big red X, and the enzyme is not working as well as it should be, so you see buildup of lyso-GL3 levels. This then raises the question of what is this variant doing, if anything, right? So looking at it in more detail, it is a common variant in the general population. In vitro studies in publications early in the 2000s show that enzyme levels can be low on the enzyme assays, but it seems to be due to the substrate that's used to actually do the test, but not really resulting in true low enzyme levels in the body. But then if you look in the literature more recently, you see publications about cohorts of patients that seem to have some more neurologic-based features. And there's this question raised about whether or not there are, in fact, features of people who have this variant. But there are some challenges there as well, in that these are patients that were ascertained through cohorts of individuals who presented with neurologic features, particularly peripheral neuropathy and chronic pain. So it's tricky, right? It's hard to understand how do you interpret this and what's the next step. One opportunity is to test a tissue of the organ system that you're most concerned about. So doing something like a biopsy of the kidney and looking for storage within the kidney tissue can really help you understand in a variant whether or not there's disease that needs clinical management. There are medications, both oral and IV enzyme therapy, available for Fabry disease. So it's important to make sure that you have the right treatment or are not treating a patient that doesn't need treatment. Moving on to another kidney condition, we've got Alport syndrome. So this is the case of a 33-year-old female with microscopic hematuria that started at age 12. She has a strong paternal family history of clinically diagnosed Alport syndrome, and she herself has no vision or hearing loss. And we'll go through her family history next. But just to highlight what's going on in Alport syndrome from a genetic standpoint, there are 3 genes that are primarily associated with Alport syndrome. The X-linked formed, but as well as both recessive and dominant inheritance patterns. And I bring this up because it gets really tricky. You've got genes that the same gene can cause both a recessive and a dominant inheritance pattern. And it can be quite tricky to understand how your patient in that family may be affected by particular variants. So looking at this family tree, you see our proband, or the patient here, is the 33-year-old with the arrow who has hematuria. She has a brother with hematuria as well. Her father passed away at age 51. He was blind in his teens, had hearing loss that developed in his 30s, end-stage renal disease in his mid-30s, and renal transplant before age 40. He has 4 siblings, 3 who are deceased at younger than age 50, and all presented with similar findings as himself. Interestingly, his parents were both asymptomatic throughout their life. And in fact, his mother, who is 100 years old and doing well, has 4 children with another partner who are unaffected. So the genetic testing here did identify a variant in COL4A3. And again, this is one of those tricky genes where it's hard to know whether or not there's a dominant or a recessive inheritance pattern for this variant, as both patterns have been reported. So Alport inheritance is one of the more challenging ones to understand. There can be reduced penetrance and variable expressivity, meaning that not every individual in the family presents the same, even if they have the same variant. Individuals with heterozygous COL4A3 variants can have benign hematuria and be considered carriers for autosomal recessive Alport syndrome. And patients' relatives, paternal relatives in this case, had an earlier onset disease more consistent with an autosomal recessive pattern, whereas our patient fit maybe more as a carrier or as more of the dominant form. It is possible that there may be more severely affected family members having a second variant in the COL4A3 gene, or it's been postulated that there can be a second variant in another gene, such as COL4A4, resulting in something called digenic inheritance. This is where 2 different genes that really work closely together can each have a change, and those things can combine and have a confounding effect. In this family, unfortunately, we'll probably never know because the relatives who were severely affected are deceased. But it gives us a good example and framework for some of the challenges with Alport. Next, we'll talk about focal segmental glomerular sclerosis. So this is a 55-year-old female with hypertension, type 2 diabetes, rheumatoid arthritis. She had severe renal stones with a history of obstruction and infection. She has diverticulitis, status post-colonic resection, and focal segmental glomerular sclerosis with associated nephrotic syndrome that's been quite tricky to treat. She has 4 healthy children in their 20s and 30s and 3 grandchildren, no family history of renal disease. So just as a background on FSGS, it's part of a genetically very heterogeneous group of nephrotic syndromes. The age of presentation is really highly variable, and there are over 40 associated genes. Large gene panel testing identifies a genetic cause in around 20 to 30% of the patients that we do test. So this is the results from her testing, and I'll point you, I guess, to first the 2 other genes listed below the gene in red, and these are both changes in recessive conditions without a second variant. So as Marina articulated and showed you the dominant pattern, this would be a recessive pattern where you would need a change on both copies of your chromosomes in order to have the condition, and she has only 1 of each of those, so we're not concerned about that. But this first one here is certainly of interest. So ANLN stands for actin binding protein anilin. This is a gene that's important in cellular growth and migration and helps with cytokinesis. It causes autosomal dominant focal segmental glomerular sclerosis 8 in just 2 families that have been reported in the literature, but it also has shown a phenotype in zebrafish as well as mice. Because only 2 families have ever been identified or at least reported in the literature, there's only 2 variants that we're aware of. And this makes it really difficult to interpret the variant, right? So it has not been previously reported. It's not common in controlled databases. It's predicted to be damaging in multiple protein prediction software programs and is the type of variant that may cause disease. So while the lab can't go to calling this a pathogenic variant and calls it a variant of uncertain significance, looking at the actual data, it's pretty convincing that this is in fact the explanation for this family. Next steps then go to how do you investigate this in the family. So we went on to test affected and unaffected family members. Her 76-year-old mother was negative for this variant and does not have renal disease. Her father was deceased, so we were unable to test him. All of her children were screened for proteinuria. Her 32-year-old son was found to have proteinuria and was positive for this variant on follow-up testing. And he is now undergoing surveillance and close monitoring. So the next step in this case is to collaborate with researchers and the folks who published those two families. We've collected patient samples and provided the variant information to those labs where they can look at zebrafish and mouse models and look to see how this particular variant in this family impacts other organisms. So I wanted to then finish up by talking a little bit about some family planning. This is a really important part of what we do in genetics, and one of the main reason that a lot of our families seek genetic testing. In order to counsel someone adequately about the recurrence risk of a genetic condition in their family, you have to first identify what the variant is. What is the actual cause of the genetic condition in that family unit? Once you're able to identify it, then there's the question of inheritance. And for dominant conditions, a parent that's affected has a 50% chance of passing it on to all of their offspring or each of their offspring. In a recessive condition, there's a 25% of passing it on if both parents are carriers. If only one parent is a carrier, then they're not likely to pass it. They're not expected to have an affected child, though half of their children will be carriers. And then in an X-linked condition, there's 50% of chance of passing it on with each pregnancy. But we see variability based on sex for who is more affected than others. So we typically see in X-linked conditions that males are more affected than females, but it remains that 50% chance of passing it on with each pregnancy. There are some other forms of inheritance that are not as common in the nephrology world, such as mitochondrial inheritance, but we didn't go through that today. It's not quite as applicable for this population. Genetic testing. So when a family wants to have answers prior to a pregnancy or during a pregnancy, there are some options there. Prior to conception, there are options to do in vitro fertilization with testing of the embryos. But this does require significant planning in advance and a high use of resources. It's also important to note that this is not something that can be done for every situation. In a child who has a de novo condition, so something that was new in them, and the parents want to know what the chances are of passing it on and want to have testing of embryos in the future, that is something that we're typically not able to do. So it can be very tricky, and it's important to counsel your families that they need to be speaking to a reproductive endocrinologist about their specific changes in order to move forward with something like IVF. There's also testing during a pregnancy, and this can include chorionic villus sampling, which is taking a small piece of the placenta, or amniocentesis, which is done by taking some of the amniotic fluid, and we can do genetic testing during the pregnancy. There's also the option of testing after birth. So in conclusion, I hope we've walked you through a little bit of how to read a genetic test report, the role of a genetic counselor, and really truly genetic counseling, and how you can integrate this into your practice. And then we've reviewed some really important genetic concepts in nephrology: mosaicism, some challenges with PKD1, genotype-phenotype correlation, and that's looking at the genetic change and seeing how it impacts the clinical aspects of somebody's care. Reduced penetrance and variable expressivity, so the differences within family members. We touched on digenic inheritance, and then gave you some tools to think about variants of uncertain significance and how to interpret those using functional studies such as metabolic labs, family studies, and ultimately collaboration with researchers. So I thank you for your attention, and I'll pass it back to Dr. Rastogi.
Dr. Russell, thank you so much. So that was an excellent, excellent overview of genetics, the primer for the modern nephrologist. So before we get into our next speaker, I just want to give a bit of a history of what we call Nephro-Genetics now at UCLA. So it was 2010 that we established the AD-PKD program at UCLA. And at that time, there's research being done, drugs, medications, but also more comprehensive care for a patient, because there are other organs that are also affected in ADPKD. We can have aneurysms, we can have liver cysts, and other organs can get affected as well, including the cardiovascular system. So we started a comprehensive program for ADPKD. A few years after that, we started a program for Fabry's disease, and then a few years Alport, and then kidney stones. And then finally, we put everything together, said we'll do a Nephro-Genetics program. And this Nephro-Genetics program would not have been possible without the help that we get from Dr. Bianca Russell and Marina. So we're very, very grateful for having them here at UCLA Health, but more importantly for our patients. So thank you very much, Dr. Russell. That was very informative, and thanks Marina, for your excellent presentation. One point that I do want to stress on what Dr. Russell went at the end is about family planning, and we should not miss that point. When a patient comes to, and I mentioned that in my opening remarks, why do the gene testing or broad panel testing for that matter? Number one is getting the right diagnosis, which is very, very important, because the management will depend upon that. And you'll be hearing from our guest speaker today about how the molecular diagnosis changed her life. Getting enrolled in clinical trials, a lot of trials going on. A lot of the medications that are coming out actually work by modulating gene expression, and a lot more will be coming out. But then also at-risk family members. So we should not be missing out on those that might be undiagnosed. And then finally, family planning. Every patient of mine who's in childbearing age gets automatically referred to Dr. Russell and Marina to get counseling on family planning for that matter. So we'll be going over the importance of testing over and over again, but it's really my honor and privilege to introduce our next speaker, and that's Dr. Park. So Dr. Park is a nephrologist and clinical researcher at University of California in San Francisco. Her research focuses on lifestyle factors and cardiovascular outcomes in individuals affected by kidney disease, especially those affected by polycystic kidney disease and other genetic diseases, including APOL1. So she's a co-PI of the UCSF Clinical Center for the NIH-NIDDK Apollo study, and is also the founder and director of the UCSF Polycystic Kidney Disease Center of Excellence. And I can just tell you, we want collaboration between different academic programs, academic centers, especially the UC programs as well. And I can tell you, Dr. Park has been amazing. So with that, Dr. Park, and you will be doing a more deeper dive into ADPKD and APOL1. So thank you very much. I like your green ribbon.
Thank you so much. I like yours. All right, great. Thank you so much, Dr. Rastogi, and the organizers of this session for the opportunity to present. I actually modified the title a little bit to say that this discussion is a deep-ish dive, because we don't really have all that much time, and both of these topics are extremely large and interesting and exciting. So we'll do our best to get as much of an overview as possible. These are my disclosures. And I wanted to start with my take-home points so that you can keep these in mind as we go through our cases. I want you to come away from this knowing that genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, and APOL1 genetic testing may eventually help to identify at-risk individuals, but uncertainties exist regarding the clinical implications. So let's get to my first case. This is a 38-year-old woman recently diagnosed with ADPKD in the setting of hypertensive emergency, which presented as epistaxis. In the emergency room during her evaluation for this, she was found to have bilateral kidney cysts and liver cysts. Her family history is notable for a father with diabetes and kidney cysts. He's currently age 70 with a GFR of 55 by report, and he's not on dialysis. She said that she had not been aware that he had kidney cysts because the father has always considered diabetes to be his major medical problem and didn't think the kidney cysts were really important. The patient's current GFR is about 100, calculated from a serum creatinine of 0.75. And her daughter, at the age of 8.5, for a variety of reasons, was actually recently diagnosed with bilateral kidney cysts as well. So this is not meant to be a talk about management of polycystic kidney disease, but just to give you a sense of how I go about caring for my patients with PKD. We're fortunate to be able to get total kidney volume measurements on most of our patients. And this patient's imaging revealed that she falls into so-called class 1C of the Mayo Clinic Erasmus classification of total kidney volume to assess risk of rapid progression in ADPKD. So this is the figure from the very heavily relied upon, quote unquote, practical guide for prescription of tolvaptan and assessment of clinical care for polycystic kidney disease patients. And as you can see, one of the major branch points comes at the point of trying to measure total kidney volume by CT or MRI and determination of the Mayo class. So since we had this detailed imaging, it might be a question of why we would need to pursue genetic testing, if at all. And to talk a little bit about the rationale for testing in this patient, I think that the concept of shared decision-making is very important. She was relatively thrown off and shocked by this diagnosis, had been very healthy most of her life, was not aware of her father's kidney cyst issue, was very disturbed to find that her daughter was also recently diagnosed with bilateral cysts. So she thought that it would be very important to have the genetic information available to her to just understand the diagnosis better. So we did pursue genetic testing and indeed found a pathogenic mutation, which happened to be in the PKD2 gene, consistent with a diagnosis of autosomal dominant polycystic kidney disease. So to talk briefly about PKD1 versus PKD2, PKD1 comprises about 60 to 80% of all ADPKD pathogenic mutations thus far described. PKD2, which encodes the polycystin 2 protein, comprises about 15 to 25%. And in evaluations of individuals with a PKD phenotype, no mutation is detected in about 10 to 15% of patients. So-called additional cystic kidney disease genes such as GANAB and DNAGB11 comprise less than 1% of the molecular diagnosis for individuals with PKD phenotypes. So what to do now with this information? Technically, she meets the threshold for so-called risk of rapid progression measured by total kidney volume, and by the practical guide, she would qualify for tolvaptan prescription. Another risk scoring system, however, that's predominantly in use in Europe, assigns lower risk to PKD2 mutations than to PKD1 truncating and non-truncating mutations. So just to remind you that the REPRISE study, which led to the FDA approval of tolvaptan, actually only enrolled individuals whose GFR ranged from 25 to 65. And notably, total kidney volume was not an inclusion criteria for REPRISE. And genotype data from REPRISE is actually not yet available either. So how do you apply these various conflicting pieces of information to make the decision about whether or not you should treat her with the only FDA-approved medication specifically for ADPKD? So this was a study that evaluated total kidney volume and genotype in the CRISP and HALT PKD studies, where both of these measurements were available. And you can see that there's actually a range of kidney volumes and so-called Erasmus class or MIC, Mayo Erasmus class designations for total kidney volume. So if you look on the right-hand side, you can see the various classes of A through E indicating lower to higher risk. and then the corresponding genotype on the other side, where of course you do see that PKD2 genotype tends to have a more mild phenotype, but that there is considerable overlap in the range of PKD1 non-truncating mutations with PKD2. So there are, in other words, PKD2 patients who do have larger kidneys for, as you might imagine, there's a range of presentations within any of these genotypes. So here you can see that those with PKD2 in the male Erasmus class of 1C did have later onset of kidney failure. But as we discussed, there is a range of disease courses. Interestingly, the rate of growth of the total kidney volume is the same for PKD1 and PKD2 genotypes, meaning that the growth over time is the same, although the sort of starting place is different between these two groups. So you might imagine that using the argument that the attenuation of cyst growth progression by tolvaptan being the main mechanism of disease could still apply in those who fall into the PKD2 genotype and may have a slightly higher TKV at the time of assessment, falling into a risk of rapid progression. For various reasons, this patient prefers not to take tolvaptan, which I actually think is quite reasonable, especially considering all of these factors and the fact that her GFR is very preserved at this time. She personally prefers to use various dietary interventions, and she's still just coping with the new diagnosis and trying to make a decision about what we would like to do in the coming months to years, working together as a team. Okay, so my next case is a 44-year-old woman, also with a history of autosomal dominant polycystic kidney disease that had been diagnosed and treated at a different center. Her father is age 65 at the time of my first meeting with her. He also had a history of polycystic kidney disease and was not on dialysis at that time. Her mother, age 65, has no medical problems. She has a half-sister by a different father who is 33 and has no kidney cysts. She does have 2 children, including a son who has a diagnosis of PKD at the age of 13. She also has a history of hernia, but no known liver cysts. She reports occasional abdominal pain, and currently her GFR is about 89. The history of her labs showed a GFR of about 111 from the earliest time point in our system. But as you can see from this graph, the slope of her eGFR change has been quite modest over the past several years. Notably, she does have a UA positive for heme since 2009. So this is a sample of her kidney imaging, revealing relatively modest kidney sizes of about only 11 centimeters on each side. And again, calculating her total kidney volume from those measurements puts her in a class of 1A Mayo classification, which is actually very relatively low risk of disease progression in ADPKD. So notably, her son is cared for by a pediatric nephrologist at our institution, and he's now age 17. His main issue is actually primary nocturnal enuresis that has been very refractory. And his most recent creatinine was 1.25, up from a previous range of 0.6 to 0.8. His UA is actually negative for heme, and his urine protein to creatinine ratio is fairly low. And since DDAVP is a strategy to treat enuresis, this actually has not been used because of this concern about the effect on his PKD cysts. This would be actually the opposite strategy from the use of tolvaptan, which of course is not approved for use in the age group less than 18, but by extrapolation of the mechanism of disease progression would be thought to be potentially detrimental. So his imaging is notable for a few scattered multiple bilateral cysts on MRI, and a more recent renal ultrasound showed that he had pretty unimpressive degree of cysts, and it was thought that given his age and lack of bilateral cysts, although on ultrasound he on MRI, he actually did have bilateral cysts, but that a polycystic kidney syndrome was probably unlikely. So to think about testing my patient, the mother of this child, and a woman with her own disease course, we thought that it would be informative for both her care and also potentially for her son's care if we could get a diagnosis in her, considering that genetic testing in her son directly would have different implications potentially than testing her. So pursuing her genetic testing, we found a pathogenic variant in the COL4A5 gene, making her have a new diagnosis of X-linked Alport syndrome. And this mutation would not be consistent with bilateral kidney cysts. So we don't really have an explanation of why she does have bilateral kidney cysts, albeit modest ones. Indeed, she could still have a PKD mutation, considering that in the Groupman paper, that was the revolutionary paper about exome sequencing in kidney disease, about 1% to 4% of patients actually did have 2 disease-causing mutations in different genes. So she certainly could be an individual who falls into that category, and it's not clear. It is possible to miss the diagnosis of a PKD1 or PKD2 mutation due to the limitations of genetic testing of this complex gene that were alluded to by Dr. Russell. So interestingly, this variant has been described before in a family with a rather severe phenotype of X-linked Alport syndrome. And as you can see in this family tree, all of the affected individuals did have microscopic hematuria and some degree of proteinuria as well. This is a different gene altogether, and I don't mean to say that this is what could be happening in our patient, but it is notable that a lot of new discoveries are being made in just the complex type 4 collagen protein, and they have different effects that have been demonstrated not only in the basement membrane, but in other disease manifestations. And in this series of COL4A1 mutation in familial kidney disease, there actually were kidney cysts that were described. So I think that it is possible that going forward, we'll learn more about potential overlaps in cyst development from collagen 4 mutations versus you learn whether or not we'll be able to detect a mutation in the PKD1 or PKD2 genes in this patient. So her clinical course was modified with this diagnosis, and she was referred for hearing and vision tests. The aortic root can be affected in PKD, and it was reasonable to get an echocardiogram also to evaluate her aortic root and valves. Her son was referred for the above testing as well, and now is actually trialing DDAVP for the enuresis. We would like to eventually confirm the genetic variant in the patient's son and father if that becomes possible, basically because of cooperation of these family members. Okay, my last case is of a 34-year-old woman with end-stage kidney disease. She started dialysis in 2018 at the age of 31. She has frequent admissions for so-called dialysis non-adherence, which unfortunately is actually due to her not having childcare during her scheduled dialysis shift. And initially, her presentation was actually due to nephrotic range proteinuria in 2007. And at that time, she actually did require, she had AKI requiring dialysis, came off dialysis briefly, but then was started on dialysis again, as I mentioned. She did not have a biopsy at the time of her presentation or at any point. She had a broad workup for glomerular disease and had a variety of negative serologies. In her medical record, chronic kidney disease that are listed as the reason for her kidney disease, including secondary FSGS from obesity, hypertensive nephrosclerosis, and quote-unquote medication non-adherence. The patient is African American, and her family history is notable for her mother also being on hemodialysis at a very young age. So to talk a little bit about ApoL1 renal risk variants, there's a region on chromosome 22 that contains genes encoding the MYH9 gene for myosin heavy chain and apolipoprotein L1. And the last exon of ApoL1 has two common variants called G1 and G2, which are in tight linkage with MYH9, and these associate with higher renal risk. High-risk variants, which are either G1, G1, G2, G2, or compound heterozygotes who are called G1, G2, have higher risk, particularly of these conditions, including HIV-associated nephropathy, FSGS, and CKD attributed to hypertension, based on case control studies with up to 29-fold or 7 to 10-fold increased risk. The population estimates of these variants are that at about 30 to 35% of individuals with recent African ancestry carry at least one risk allele, and it's thought that at least 12 to 13% carry two high-risk alleles, although only about 20% of these individuals will have overt kidney disease. So we did pursue genetic testing in this patient in an effort to better understand her disease and her need for kidney dialysis at such a young age, and to also, to some degree, help the patient to understand why this had happened to her, and to try to combat some of the language sort of used in the medical record about her non-adherence, her supposed non-adherence, which she had been sort of labeled with. So indeed, she had two G2 increased risk alleles, indicating that indeed she had ApoL1 mediated kidney disease. And her mother underwent the genetic testing as well for the same reason and was found to actually have a G1 and a G2, meaning that the patient clearly inherited the G2 from her mother and that her father is either a heterozygote carrier of G2 or may have either just one copy or another copy of non-higher renal risk variant. Unfortunately, we are not able to test her father to know for sure, but he definitely had at least one G2. So what does this information do for our patient? She's already on dialysis at a young age, so it's not like we have this genetic information and can predict that she's going to have disease progression or be at higher risk per se. She does not have diabetes. There has been an observation that there might be increased survival on dialysis due to reduced subclinical atherosclerosis development in individuals who have the renal risk variants of ApoL1. And this was evaluated in a population of about 400 dialysis patients in whom ApoL1 gene status was available. And here you can see that the non-diabetic patients with two risk variants actually had a statistically significantly longer survival on dialysis. There have also been conflicting results from other studies, but there is some scientific underpinnings to this that would suggest that there is less aggressive atherosclerotic development as a result of these renal risk variants. So how would this affect her ability to be transplanted one day, since she is so young and it is extremely difficult for her to undergo dialysis? So it's estimated that about 23% of first-degree relatives of Blacks with non-diabetic kidney disease are projected to have two risk variants. barring potential donors with 2 renal risk variants could have numerous disadvantages, including further reducing access to living donation among African Americans and potential psychological distress from having a diagnosis of this risk and not necessarily having kidney disease. It might be appropriate eventually to get to a point where we actually have a method for assigning a threshold for age and assessing a risk for a second hit among 2 renal risk variant carrying individuals. And I'll talk a little bit more about what I mean by a second hit in a couple slides from now. So, considering that if 2 renal risk variants in donors really does accelerate progression of disease to end-stage kidney disease, it might be reasonable to exclude those with 2 renal risk variants from donating a kidney. And actually, a very small study does show about a 10% rate of end-stage kidney disease in living donors with 2 renal risk variants, although this is currently the subject of larger evaluation in the Apollo consortium, as alluded to by Dr. Rastogi, of which our centers are a part. So this patient was eager to have more understanding of her disease, as I had mentioned, since she was so young, and we discussed the pros and cons of genetic testing. But what are community member views on APOL1 testing? This study was conducted among 39 participants who were representative of a African American patient population in a variety of cities in 2019. And this group expressed unanimous support for testing so-called cadaveric or deceased donor kidneys that were being transplanted. There was near unanimous support for offering testing to living donors with counseling, but sort of dispute about whether it should be mandatory or not. And notably, 90% actually opposed barring living donation from individuals with 2 renal risk variants. 64% endorsed universal testing for Black patients, although this was sort of further delineated into only about 21% favoring offering the test to those with CKD risk factors, and 10% thought that only patients with signs of CKD should be offered testing. So I mentioned the second hit that is thought to be the precipitant for kidney disease in individuals with 2 renal risk variants of APOL1. And here is a schematic describing what that means exactly, in that podocytes with APOL1 high-risk phenotypes is the first hit, and then a second hit actually is thought to be mediated by increased interferon levels. And this can be due to viral infections, for example, HIV, as has been described in terms of HIV-associated nephropathy, and also various drugs or inflammation, such as lupus. And this second hit is what precipitates the cellular swelling, mitochondrial damage, and then downstream effects of cellular disruption that eventually leads to podocyte effacement, albuminuria, proteinuria, and inflammatory response that leads to the phenotype of APOL1-associated FSGS nephropathy or HIV-associated nephropathy, seen as collapsing glomerulopathy on biopsy. So it's 2021. We're still dealing with COVID-19, and it's notable that it has indeed been shown that those with an APOL1 high-risk genotype can be susceptible to a second hit from COVID-19. So here is a series that was published very recently, given our ongoing battle with COVID-19, which shows features of COVID-19 glomerulopathy in APOL1 high-risk genotype patients, including collapsing glomerulopathy and foot process effacement. So to get back to my original take-home points, genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, as in our second case. And I think that the future will show an evolution in terms of how we use APOL1 genetic testing, but we may eventually be able to help identify at-risk individuals, perhaps understand better how to attenuate effects of the so-called second hit, but uncertainties still exist regarding clinical implications. Thank you so much, and I know we'll get questions in the panel discussion, but you can also email me anytime at pkd@ucsf.edu. Thank you so much.
Thank you. So thank you, Dr. Park, for that excellent discussion. Just some key points that Dr. Park brought in our discussion, the shared decision-making. I think that's very important. And we'll be discussing that in our Q&A section as well. But also, so what other benefits can the gene testing or genetic testing do? One was to risk stratification, especially in our patient with ADPKD and rapid progressors, but also getting the correct diagnosis. And this we have seen, Dr. Park mentioned a few trials, including the REPRISE study as well. And we were part of those trials at UCLA. The correct diagnosis is important. Just because you have cysts in your kidneys and multiple cysts doesn't mean that you have ADPKD, and there are alternate diagnoses. And once again, we'll be discussing that in our Q&A section. But it's important to get the right diagnosis, because if you don't get the right diagnosis, you can't get the right treatment and actually can be getting potentially harmful treatment. So that's where the key is, the diagnostic portion. So with that, we'll be taking a bit of a break. We'll be back in 15 minutes. And we'll have a wonderful lineup of speakers to continue. Thank you.
From a simple blood or saliva sample, Natera's Renasight Kidney Gene Panel provides you with clinically relevant data about your patient's kidney health. By identifying if there is a genetic cause of their kidney disease, or if they may be at increased risk due to family history. A genetic finding has implications for clinical management in 89% of patients with chronic kidney disease. Renasight analyzes over 380 genes associated with kidney disease that were selected by genetic experts to provide clinically relevant information. It uses the latest advances in next-generation sequencing to deliver greater than 99% detection rate across genes screened. Natera is committed to making the Renasight test accessible to all patients. We welcome all insurance plans and provide affordable testing through a variety of payment methods, including discounted self-pay options and financial assistance through our Compassionate Care program. Natera offers a suite of services to make ordering easy for you and your patients, including remote testing services and complimentary information sessions with one of our board-certified genetic counselors. That's how Natera is tirelessly working to empower you to discover more answers about your patient's kidney health.
Welcome back. And it's my distinct pleasure and honor to introduce my next speaker, Dr. Patricia Wang. Dr. Wang graduated from Icahn School of Medicine at Mount Sinai and completed a pediatric residency at Yale New Haven Hospital in New Haven, and a pediatric nephrology fellowship in Icahn School of Medicine at Mount Sinai. After several years as a pediatric nephrologist attending at Mount Sinai and New York Presbyterian Morgan Stanley Children's Hospital at Columbia University, she came to UCLA in 2013 and has risen to the ranks of Associate Professor of Pediatrics. She also serves as a program director for the Fellowship Training Program and the interim director for the Pediatric Kidney Transplant Program as well. So Dr. Wang, and she will be talking about role of genetics in pediatric kidney disease.
Thank you so much for that introduction, Dr. Rastogi. So I will talk about genetics in pediatric kidney disease and go through a couple of cases highlighting instances where it's really important to obtain genetic testing in our pediatric CKD population, and also relate that to adult nephrology and adult CKD. My only disclosure is that this This presentation is being supported by Natera. So I'll first go into a case of an 18-month-old girl who was evaluated in the pediatric nephrology office for a history of gross hematuria, which is now resolved by the time the patient came to see us. The patient had a 1-week recent history of a URI that was afebrile. She had some rhinorrhea and a cough. Otherwise healthy, born full term, normal spontaneous vaginal delivery, no problems during the pregnancy, no significant past medical history or surgeries, no hospitalizations. On a repeat urinalysis in the office, she was found to have dark amber colored urine, over 1,000 red blood cells per high power field, no proteinuria, and a urine protein creatinine ratio was done, which was 0.4, which for her age group is normal. Further labs were all normal, including hepatitis, ANA, ANCA, complement levels. The rest of her CBC and her CMP were all normal. After much discussion with the parents, we opted to observe the patient, and the patient was seen every 4 months for the next year, yet she developed an increase in her urine protein to creatinine ratio from 0.6 to 1.0. The parents at that time refused a kidney biopsy due to the patient's young age and the parents' reluctance to have the patient undergo anesthesia at that young of an age. Over the course of the next year, the gross hematuria resolved but recurred between 5 and 6 times, usually associated with a URI, but sometimes it didn't seem to be temporally correlated with any URI symptoms. The differential diagnosis to our team was a post-infectious glomerulonephritis, IgA nephropathy, thin basement membrane disease, and possibly some other type of glomerulonephritis. At age 3.5, the parents finally agreed to have a biopsy done when the urine protein to creatinine ratio increased to 1.2. The biopsy showed on light microscopy some interstitial fibrosis. The immunofluorescence showed an absence of alpha-5 type 4 collagen and a mosaic patchy staining. EM showed diffuse thinning of a GBM and few areas of irregular and multilaminated appearance of the lamina densa, one sclerosed glomeruli, and mild effacement. The diagnosis was hereditary nephritis or Alport syndrome, autosomal recessive type on subsequent genetic testing. Clinical significance for this case is that Alport syndrome or hereditary nephritis does have, as we've heard earlier in this session, extrarenal manifestations, including sensory neural hearing loss and eye findings. Knowing the clinical diagnosis will enable us to counsel the family in terms of future family planning, to look for these extrarenal manifestations, and to see how carefully we really need to monitor kidney function. So genetics could have been aided in earlier diagnosis, which was ended up being completely different from what the clinicians had initially predicted. So in this case, the genetic testing did not really coincide with what we thought would happen clinically. And this case, I think, reflects what everyone has been saying so far, that genetic testing is really important for therapy planning, family planning, and for looking for other extrarenal manifestations that can impact the patient. So the benefits of knowing the genetics of a disease include heritability and family planning to actually know the precise, accurate diagnosis, for counseling for risk of recurrence after a kidney transplant, looking for extrarenal manifestations and monitoring of these extrarenal symptoms. And this can also help advance the understanding of biology and science involved in kidney disease, which can improve therapeutics in the future. So why is genetics important? The heritability of GFR, or glomerular filtration rate, is estimated to be about 30 to 60% in the general population, and other parameters such as also tubular transport of electrolytes similarly show substantial heritability. Moreover, about up to 30% of adult patients with ESRD report a positive family history across different ethnicities and etiologies. The prognosis, disease course, and appropriate management can then therefore differ markedly between hereditary and acquired forms of kidney disease. But these forms can be really indistinguishable when traditional diagnostics are done alone. So the cause of kidney failure is actually classified as unknown in more than 1 in 10 patients with ESRD. So thus, earlier and more specific diagnoses are needed to enable a delivery of effective care. So in terms of genetic epidemiology, there's a total of approximately 25,000 genes. Of these, they constitute about over 5,000 Mendelian disorders, and approximately 450 monogenic genes are known to cause CKD. Of these, 30% are known to cause CKD in the pediatric population. These are rare disorders, yet these genetic birth defects can constitute about 8% of live births. And up to 50% of individuals with rare genetic conditions can remain actually undiagnosed. Traditional genetic testing has been utilized to detect rare variants in individuals with suspected monogenic disorders. And traditionally, genetic testing has been used in the realm of prenatal screening and the diagnosis and individualization in cancer therapy. But more and more increasingly, the new genetic technologies are increasingly being applied in non-invasive kidney diseases and for prognostication in patients with kidney disease. So there are a wide variety of inherited kidney disorders. There are several hundred genes that are implicated in human kidney disease. And there are so many, for instance, just for podocyte biology, which can cause nephrotic syndrome, there are over 50 genes that are implicated. It's way too many for, I think, most clinicians to memorize and remember, especially also since many kidney disorders can also be thought of as complex or multifactorial, which is caused by a combination of both genetic and environmental risk. So with this wide spectrum of variety, where about 10% of ESRD has a genetic cause in adults and up to 70% of ESRD in pediatrics, it's really important that genetics play an important part in the workup of these patients. Just showing this slide, which has been seen, I think, in many different iterations in the past of causes of ESRD, where you can just see that the top causes of pediatric end-stage kidney disease are CACIT, or congenital anomalies of the kidney and urinary tract, which encompasses renal aplasia, dysplasia, hypoplasia, obstructive uropathy, and nephrotic syndrome, FSGS, and membranous nephropathy, congenital nephrotic syndrome. And I'll go into a little bit more detail in this talk about some of these primary causes of pediatric ESRD and how it relates to genetics. So monogenic kidney diseases can be classified based on the mode of inheritance, as we've heard earlier in this symposium, into autosomal recessive and autosomal dominant. Dominant disease genes may also be manifest by de novo mutations, which are also known as non-inherited mutations. This phenomenon is virtually absent from recessive diseases because it's extremely unlikely that you can have two de novo mutations occur in the same gene spontaneously. In recessive disease, both parental copies or alleles of the monogenic disease gene need to be abnormal or mutated for the disease to actually manifest symptoms. In recessive disease, this is often called full penetrance. An example of a recessive disease that we see in the pediatric population quite often is autosomal recessive polycystic kidney disease, and a dominant disease is autosomal dominant polycystic kidney disease. Just moving forward a little bit, just to talk a little bit more closely about the penetrance of these monogenic alleles in autosomal recessive versus autosomal dominant disease. You can see here in this chart, the x-axis shows the age of disease manifestation in years. And so you can see in the dark blue line, if you have a very strong mutation, i.e. a homozygous truncating mutation, which can be shown to be a very strong allele where the penetrance is quite high in an autosomal recessive gene, you can manifest symptoms at the age of 10 years. For another individual with a homozygous mutation in the same disease gene or a mild allele, the age of onset may be a little bit later, and you see the curve move to the right. The curve can move back forwards and to the right and to the left based on the environment too and other factors. So just a very incomplete list of some different types of monogenic kidney disease. There For nephrotic syndrome, there's FSGS caused by MPHS1, MPHS2, nephrin and potosin, LAM2, TRPC6, alpha-actinin 4, which are more predominant in the adult population, causing genetic FSGS. CACIT, which can be monogenic or polygenic in its inheritance pattern, can be caused by a very large list, which I'll go into in the next slide, of genes that are mutated in SOL1, RET, PAX2, EYA1, and other renal tubular disorders such as Barter's, Gittleman, and nephrogenic diabetes insipidus. Some renal cystic ciliopathies that have already been mentioned in this symposium so far, ARPKD, ADPKD, they are all known to be to manifest through monogenic mutations. In addition, nephronophthisis, primarily a pediatric cystic kidney disease, which is caused by up to 20 different mutations, can also cause nephronophthisis. And then Bardet-Biedl syndrome, a syndrome that encompasses a renal cystic disease, and often these patients will require a kidney transplant or some other form of renal replacement therapy. There have been up to at least 22 genes at my last check that are responsible for the renal phenotype in Bardet-Biedl syndrome. So for polygenic diseases on the other side of the spectrum, it's characterized by a weak genotype to phenotype correlation. These diseases usually manifest in adulthood and have a weak heritability pattern, which is really subject to modification through environmental factors. So CACIT, the congenital anomalies of the kidney and urinary tract, I had mentioned earlier, can be caused by a monogenic cause, but it can also be part of a syndrome, and it can also be thought to have many different genes, and the environment can also impact the development of CACIT. I just listed a little bit the different types of CACIT that I'm talking about: renal agenesis, hypoplasia, cystic dysplastic kidneys, and vesicoureteral reflux. Nephrolithiasis, kidney stones, is also can be thought to be a polygenic kidney disease where there is a weak genotype-phenotype correlation, but there are some specific diseases that can cause nephrolithiasis and be caused by just a solitary gene mutation. So polygenic diseases can be characterized by a weak genotype-phenotype correlation, and it's usually manifest during adulthood as opposed to in the pediatric age group. This is just a slide looking at the different types of CACIT, and like I said before, up to about 20% of CACIT cases can be thought to be responsible by these monogenic gene mutations, and it can be part of a syndrome, yet it can also be this phenotype can manifest individually, separate from an actual syndrome. So CACIT is important because it can encompass about 40% of ESRD in the pediatric population. It's a frequent cause of birth defects, 1 in 1,000 live births, and there have been over 200 clinical syndromes that can have CACIT as part of the renal phenotype, and 40 different monogenic causes of human CACIT, 25 being dominant and 15 being recessive. Along the same lines, for glomerular disease, nephrotic syndrome can be caused by a single gene mutation, such as in nephrin and potosin, which I alluded to earlier, or it can be part of a syndrome, such as the ones listed here on this page. So just in terms of thinking about syndromes, I wanted to talk to you about my next case, which is a 3-year-old girl who had a history of renal dysplasia, was on peritoneal dialysis, referred for evaluation in my office for a kidney transplant. She received a kidney transplant after 1.5 years on peritoneal dialysis. Her postoperative course was pretty unremarkable, except for elevated blood glucose level in the hospital, which was thought to be due to steroids. Her creatinine was normal for age at 0.3, and her medications were the classic medications that we use after kidney transplantation: prednisone, mycophenolate mofetil, tacrolimus, cotrimoxazole, and valganciclovir. As an outpatient, she's continued to do well. Her blood sugars still ran high in the 250 to 300 range despite fasting. Genetic mutation was done 6 months after transplant, which revealed an HNF1 beta mutation. So at the same time as all of the whole workup for genetics and to see why she had persistently high blood sugar levels. The patient developed acute cellular rejection, received a steroid pulse and anti-thymocyte globulin for treatment, but unfortunately, due to this treatment that would reduce her immune system, she developed norovirus diarrhea, which hindered treatment. She didn't actually get complete treatment of her cellular rejection. Her cellular rejection continued, progressed. The diarrhea progressed. She had multiple episodes of acute kidney injury. We ended up decreasing her immunosuppression, her mycophenolate mofetil, and she eventually developed cellular rejection and aggressive antibody-mediated rejection in addition. So 1 year and 3 weeks after receiving a deceased donor kidney transplant, the patient was restarted on dialysis. So this case just illustrates that the parents were quite overwhelmed with the amount that they had to learn with their child having this new diagnosis of diabetes, in addition to having rejection and dealing with the kidney transplant. So it was just a stressful time for the family, and it would have been nice if we had genetic testing available to help with family counseling and planning and just realistic prognostication for the family. So HNF1 beta, just to quickly go over it, it's a syndrome which encompasses renal cysts and early onset diabetes. HNF1 beta is a transcription factor that's expressed in the kidney, liver, and pancreas. It's usually inherited in a dominant fashion. And like I said, it can cause cystic dysplasia, MODY, elevated liver enzymes, and you can also have magnesium wasting. So in this just pictorial, it just shows the different organ systems are involved with HNF1 beta, from the GI system to the kidneys and the CNS. So due to the strong genotype-phenotype correlation of almost 100% that's seen in renal recessive diseases, just wanted to talk about, again, how important it is that these patients get seen by a geneticist and by a genetics counselor and by a nephrologist. Especially in single-gene renal disorders, it's important to know the diagnosis that allows for prenatal diagnostics, can precisely reveal the primary cause of the disease. There's high diagnostic and prognostic value to this, and this really allows, in pediatrics especially, to have us undergo personalized medicine for our patients. Since the recessive mutations, like I said, conveys almost 100% risk that the patient will develop disease by the time they reach adolescence. An example of this is ARPKD. So there are a lot of overlapping symptoms and signs between the genotype and the phenotype, and this can be used to help inform prognosis and management. So for example, genetic testing can help distinguish between Alport syndrome and the related milder disorder, thin basement membrane disease. Both of these hematuria nephropathies do result from mutations in the COL4A3 to 5 genes. Despite such a high genetic and phenotypic overlap, the two conditions nevertheless differ markedly with respect to clinical outcomes. Alport syndrome patients really have a more severe disease with extrarenal manifestations such as audiologic or ocular deficits, which we've discussed earlier, and they can progress earlier to end-stage renal disease, requiring a transplant and/or dialysis. Importantly, the genotype level mutation can also help predict phenotype. So in general, biallelic COL4A3 and COL4A4 or hemizygous COL4A5 mutations result in Alport syndrome, whereas heterozygous COL4A3 to 4 mutations result in thin basement membrane disease. Thus, genetic testing can provide valuable prognostic information and guide further workup and management, such as informing the appropriate timing of transplant referrals and pursuing evaluations for visual or auditory symptoms among Alport syndrome patients. So shifting a little bit towards adult monogenic kidney disease, currently about 30% of CKD with the onset less than 25 years can be attributed to an established monogenic cause. However, there's significant variability in the reported prevalence of monogenic causation depending on the underlying actual CKD phenotype. And so Mallet, in 2017, did a study using a gene panel of 207 genes. And these genes were sequenced in patients that had a familial nephropathy, and a monogenic cause was found to be detected in about 43%, about 58 of 135 families. So using this curated panel of genes, they could assess that there was a substantial proportion of these patients and these families primarily made up of adult CKD patients that ended up having a genetic cause for their disease. In another study using a whole exome sequencing analysis, Lata et al. In 2017 demonstrated that in 20% of adults with CKD, a causative mutation in a known monogenic CKD gene could be identified. Their cohort consisted of 92 patients with CKD attending a tertiary nephrology center in the United States, adults presenting with CKD with one of the following diseases that are listed there: glomerular disease, tubular interstitial, undiagnosed hypertension, or the developmental disorder, were submitted for whole exome sequencing analysis. And the cohort was enriched for patients with either a family history of CKD or undiagnosed CKD, like I said. So interestingly, using this method of whole exome sequencing, this actually led to the reclassification of diagnosis in 6 of 19 families, while this actually established the diagnosis in 7 of 19 families that were initially thought to be just unknown. So genetic testing can help in all of these regards in terms of actual precise diagnosis, confirming diagnosis, reclassifying, especially reclassifying from a family or a patient that is thought to have an undiagnosed mutation. It's quite important for them. So this is just another study that was done in 2020 by Hildebrandt's group, which looked at many different studies and the diagnostic yield that was being reported from adults versus pediatrics in terms of molecular genetic analysis for the diseases listed there: nephrotic syndrome, CACIC, chronic glomerulonephritides. Molecular genetic testing was performed by exome sequencing, or a gene panel sequencing was done. For disease subgroups with more than 2 studies, the median diagnostic yield is listed there, and that was used. Interestingly, there wasn't a huge difference in the number of patients that were diagnosed in adults versus pediatrics for some of these subtypes. And then this is just another study that was done out of Ireland, which looked at using whole exome sequencing in 114 patients that included 138 affected individuals with CKD. Affected individuals were mostly adults, and then they had a positive family history. Quite a number of them had extrarenal manifestations, and some had family history, some didn't have any family history. So it was a big conglomerate of different types of patients and families. They detected a mutation in about 37% of these families, and there was also about 70% of these families were found to have extrarenal features. So this also shows that if you look closely at the slide, on the right-hand side, it shows that there's actually no difference in the rate of genetic diagnosis in individuals with a childhood versus adult CKD, which is very interesting. So a lot more still needs to be done in terms of research in this realm. Just skip over that. Okay, so just going quickly into specifically steroid-resistant nephrotic syndrome and the genetics of it. About 30% of FSGS is thought to be steroid-resistant and can present with recurrence in kidney transplant. The most commonly known genes are nephrin and potassium, which are listed here, which can cause congenital nephrotic syndrome and non-familial childhood steroid-resistant nephrotic syndrome. So genetic form is important to know because it can help with predicting progression to ESRD and the likelihood of recurrence after kidney transplant. And it can also help guide with treatment. So if you have a genetic form, most likely you're not going to respond to steroids, and you can try to prevent the patient from taking steroids and having all the accompanying side effects of steroids. So this is just a slide looking at the genetics of steroid-resistant nephrotic syndrome. There are 3 different studies done in 2015, 16, and 17. All of them use different curated gene panels looking at the genetics of nephrotic syndrome. And you can just see that there is just a much higher rate of a genetic cause to be found in the pediatric kidney disease patient versus in adults. So in terms of histology and genotype correlation, like I said before, there can be actually quite a poor correlation between the histological findings and the underlying actual genotype, which I discussed earlier with Alport syndrome. There's a huge phenotypic variability with the collagen genes, especially COL4A3, 4, and 5, which can have nephritis that may phenocopy as nephrosis. So the 2 studies that were done here that are listed with Sen and Mallet show that adult patients with nephrotic syndrome are often found to have mutations in an actual collagen gene. So this is just important to know in terms of therapies and predicting recurrence in the future for after transplant and looking at extrarenal manifestations in these diseases. Quickly turning to next generation sequencing, NGS or next generation sequencing is also known as massive parallel sequencing. It's an innovation that enables rapid and relatively inexpensive sequencing of multiple genes. And there's 2 different types of next generation sequencing that we like to use. Whole exome sequencing, which targets all coding regions in the human genome, and whole genome sequencing, which targets just the coding and the non-coding regions in the genome. And so the diagnostic yield for using NGS in pediatric kidney disease is quite high. Usually, so NGS has been listed as one of the reasons why we now know that copy number variations and neurocognitive defects are associated with kidney disease in children. So a lot of children have developmental delay, and this is thought to be due to copy number variations, and it can also cause renal dysplasia and hypoplasia, CACIT of all different types. And the copy number variation has only really come to light with the advent use of next generation sequencing. Next generation sequencing can also be helpful in diagnosing FSGS, renal ciliopathies, and MPGN or atypical HUS. It's, for example, the discovery of variants in the DGKE gene, which encodes intracellular kinase expressed in the endothelium, platelets, and podocytes among individuals with MPGN and or atypical HUS, has really helped us to better understand how signaling disruptions lead to endothelial damage, complement, and podocyte dysregulation. So in the last few minutes, I'll just go through another case. This was a case I saw, I think, about 7 years ago here in LA. It's a 4-year-old Asian male who initially presented with developmental delay at age 5 months, was evaluated by neurology for seizures, and the EEG did show that the patient had persistent seizures and had slightly decreased volume on a brain MRI. Clinical history, 2.5 years later, the patient developed generalized edema. The urine protein to creatinine ratio was 16. A urinalysis was devoid of any red blood cells. Albumin was low at 1.5. Patient was started on prednisone, a standard dose of 2 milligrams per kilogram per day, had no response after 2 months of treatment. The creatinine was a little bit high for age at 0.7. No significant past medical history, no consanguinity. The father's cousin did have a history of epilepsy, but no history of kidney disorders. Patient is not on any chronic medications at the time of the generalized edema starting. So the patient was biopsied, and it showed extensive foot process effacement by EM. 20% was completely sclerotic in the glomeruli, and there was partial consolidation of a capillary tuft and prominence of overlying glomerular epithelial cells and some adhesions. So we ended up doing genetic testing with whole exome sequencing, and we did Sanger sequencing for confirmation and found the patient had a new novel mutation, a nonsense de novo heterozygous mutation identified in TRIM8, which was disease-causing and caused the patient to have both seizures, developmental delay, and nephrotic syndrome. So the lessons learned from this case, knowing the genetic cause can really help with prognosis and genetic counseling. The parents wanted to know the likelihood that this gene would be passed along to any future children that they would have. Transplant disease risk, the patient actually is now transplanted and the disease has not recurred, most likely because he does have a genetic mutation. And we were able to really avoid immunosuppressive agents, which, as we know, have a lot of different side effects associated with them in this patient. So genetic testing can also lead to advancement of research and our understanding of nephrotic syndrome and other kidney diseases. So conclusion, there's a good proportion of kidney diseases that have a monogenic kidney mutation. It's much higher in pediatrics than in adults, but it's still important, I think, for the adult population to undergo genetic testing for the reasons I've outlined in the past. It can lead to disease reclassification. It's important for future family planning and for transplant outcomes, and also to monitor for extrarenal manifestations. Thank you. And I will take questions in the Q&A, and I will hand this back over to Dr. Rastogi.
So thank you so much, Dr. Wang. That was great listening to the perspective from a pediatric nephrologist. So a couple of points. So when we think about gene testing or genetic testing in adult patients, we normally tend to look at patients who have strong family history, familial, or they're actually younger adults. But as you heard from Dr. Wang, in pediatrics, they do a much more bigger, broader application for genetic testing. And the question that we need to ask is there a role for a broader indication for gene testing in our adult patient with kidney disease? And this we'll be discussing in our Q&A session. So if you have any questions, please put that in the chat box. We will try to answer as many questions as we can. We already have quite a few of them, but we would like to hear more. My next speaker is Dr. Yasir Qazi. After serving as an assistant professor of medicine at Erie County Medical Center and then starting the first pancreas transplant program at the Erie County Medical Center in Buffalo, New York, Dr. Qazi moved to Southern California to head the kidney pancreas transplant program at Keck School of Medicine at USC. Dr. Qazi has received over $3 million in research grants and has authored numerous papers and publications. His current area of interest includes utilization of biomarkers for improving kidney transplant outcomes. In addition to his clinical and research endeavors, Dr. Qazi is currently the director of the Kidney Transplant Fellowship Program and has trained several fellows in the field of transplant nephrology. So with that, it's my distinct pleasure and honor to introduce Dr. Qazi.
Thank you, Dr. Rastogi. Thank you, Natera, for inviting me. It's a pleasure to present our data on how we have incorporated genetic testing in our transplant setting. As we know, kidney transplant offers the best form of renal replacement therapy for individuals who are thought to be deemed appropriate candidates with a quality of life and a survival advantage. As of December 2018, there's about 500,000 patients that are on dialysis, and about 90,000 of them are awaiting a kidney transplant. End-stage renal disease, as we know, is on the rise, and other than some states in the South, Southern California is the incidence of end-stage renal disease is definitely on the rise, and with the shortage of organs, unfortunately, our patients are waiting, and it's not uncommon for some individuals to wait about a decade before they get a kidney transplant. A recent paper that was published in the New England Journal of Medicine reassured that there have been improvements in the 10-year survival outcomes. But again, we are still losing allografts, about 35 to 40% of them, 10 years after transplant. And while there has been a survival advantage that kidney transplant has been shown, once allografts fail and people go back on dialysis, we know that the mortality goes up significantly, both as a result of cardiovascular and infections. So it becomes really imperative to make sure that the kidneys last for as long as possible, and we can identify the etiology of what is causing allograft dysfunction. This paper looked at I tried to identify the specific causes of kidney loss, and as we can see, while rejection and medical complications are important components early on, it really is glomerular lesions and fibrosis, unchecked fibrosis in the allograft that is causing the eventual demise of the allografts. And there have been several registries that have actually looked into the incidence of recurrence and then the impact that recurrence has. And there is a substantial graft loss that can happen once the diseases come back, especially with some glomerulonephritis. So it becomes important in trying to identify the etiology of the end-stage renal disease, both for the recipient and the live donor. I mentioned that the wait time in some regions of the country is almost a decade. So of course, we try to promote living donors, but about 10 to 25% of the patients may notify a CKD that is of a familial with some familial history, so it becomes imperative that we identify it so that it does not have any consequences on the donor. The great thing has been the introduction of diagnostics in our field, and just in the past few years, we've seen so many biomarkers that have been added on to our clinical practice that we are detecting injury early on. In addition to biomarkers in the blood, we are also now having a more sophisticated microscopy that is helping us identify and find out what the etiology of the injury might be. This is a slide I made about 2 years ago, and just within the past 2 years, now we are incorporating genetic testing into this as well. So when we see a patient in our transplant clinic, it sort of hits a hard reset. It gives us an opportunity to uncover an etiology that might have been missed. It's not uncommon for individuals to never have sought healthcare, and the first time they actually present with ESRD, it's their initial presentation. They end up in an emergency room. All of us have seen patients with a hypertensive crisis or nosebleeds, and subsequent to that, they end up on dialysis, and there really has not been an effort to uncover what original cause of the ESRD was, because the kidneys are shrunk and it's way too late. On the other hand, we might have patients that have contraindications to a biopsy, so the etiology was really not uncovered. So when a patient does get referred over to a transplant center, we begin the process of trying to uncover what it might have been, and we spend some time. It's not uncommon for us to try and see if they've had a biopsy at some other institution to seek to get those results. The problem is, most of the times, these histopathologic lesions aren't really specific to a diagnosis, to a cause, and are not unique, and they don't really have specific therapy, nor are all kidney diseases diseases of the kidney. And over the years, we're starting to recognize that it is sort of, as an example, a TMA, we're finding mutations that is kind of like giving us a better insight into what might have been the etiology for some of those conditions. And to some extent, historically, nephrology has kind of like been defined by what we saw in pathology. So if we saw something like this, we call it membranous. We're now finding out that there might be an antibody called the PLA2R antibody. And now we're finding that there might be sort of genes that might be predisposing individuals for this. So it's sort of kind of like we've kind of existed backwards when it is now at a time that we are discovering genes that are helping us maybe put all the pieces together. And you've heard in the sessions earlier today how next generation sequencing is helping us understand the molecular pathogenesis of disease. And not only are we just discovering genes, there is an effort to try and put clinical sort of a symptomatology in the context of these. For example, we are now looking at the coenzyme Q-related mitochondrial dysfunction in the podocyte, and there's now the potential of giving them therapy and halt the progression of the disease. In a similar way, the cholesterol efflux and metabolism in the podocyte is now the source of a study that would prevent the progression of Alport syndrome using a drug like ezetimibe in a trial in Miami. So there are a lot of recent publications and papers that are demonstrating the ability to detect genetic variants. And just to quickly go over a summary of some of them, we heard about the Groupman paper. Again, landmark paper published in the New England Journal of Medicine, 3,000 patients with an incidence of about 9%, and about two-thirds of these were autosomal dominant, and few patients actually had double mutations that were discovered. This was a study that actually looked at the incidence of genetic disorders in families. So that while the previous paper was across the board 3,000 patients, this was more specifically related to the families. And you can see the rate of picking up on a mutation went from about 9% to about 40% when you had when you had a family history. Another paper, almost the same, about 70%, if you had a family history, a higher rate of detection of mutations. If you had extrarenal manifestations, again, you were able to pick up more mutations. So the testing was able to help confirm diagnosis. It was able to even establish diagnosis in some individuals that did not have a diagnosis before. We heard about the pediatric paper. This was a study from the Boston program, and they found a mutation in a significant number of patients as well. Again, sort of suggesting if there was a family history, the yield of detecting these tests was pretty significant. Now, there's been some recent literature that has been looking into the transplant as well, and two papers that I'm showing you are from just this year, a study from Germany which looked at their wait list and kind of worked folks up if they had not had a diagnosis. So if you can see on the right, it's sort of like the algorithm they used. Basically, if you were less than 40, if you had an unusual etiology like FSGS, so they tested those folks for genetic testing and identified mutations, again, in a significant number of patients, about 20%, and many of them pathogenic. There was another study from China who kind of looked at the same, or broke it down by familial or folks that did not have a family history. And again, the rates sort of correlate what other investigators are basically seeing. Interestingly, in this paper, they also identified some oncogenes. And as transplant nephrologists, we're always worried about post-transplant malignancies. So the ability to detect oncogenes seemed to help at least guide management or be more proactive about looking into that. So collectively, the data that I have shown you sort of suggests that it is possible to identify monogenic genetic mutation, especially if there is a strong family history, if there's an early onset of chronic kidney disease, if there's an unknown cause, and there is an extrarenal manifestation. So with all this data that has been coming out, it becomes important to see what role genetic testing can play in kidney transplantation. And obviously, we're looking at it both from a recipient standpoint and the live donors to whom we basically want to make sure that they do not have any risk factors long term. I talked about the importance of recurrence in terms of the long-term survival of the allograft, but there are other things that are also important in terms of what implications the etiology might have. And I want to underscore the importance of putting the diagnosis right. in the United States, when somebody goes on the wait list, they are assigned a score called the estimated post-transplant survival, basically looking into 4 variables: age, whether they were on dialysis, if they were on previous recipients, and what is important is like if they are diabetic or if they're not diabetic. So I've put up 2 scenarios for the same age, same duration on dialysis, and give them the diagnosis of diabetes and not. And you can see that they become eligible for the best quality kidneys if they have a lower estimated post-transplant survival. So it becomes really important to identify. Literally the day I made this slide, next day in the clinic, the first patient that I saw had a history of diabetes, but no diabetic retinopathy, was not on any diabetic medication, had been on some steroids. So clearly diabetes may not have been her original etiology, but if that got put on the form, there is a chance that she may lose out on potentially good quality kidneys because the estimated post-transplant score works out to be different. So I sent a genetic testing on her, and this was just a few days ago. So obviously it'll be something that we look into because we definitely don't want them to be disadvantaged on not being able to get a good quality kidney as a result of an inaccurate diagnosis. While there is also a lot of work happening in terms of assessing for rejection and tolerance. While this is not part of the genetic testing that we have been doing, but just to kind of show you guys, literature is looking into particular gene sequences that might be promoting tolerance or putting people at risk, and also whether individuals may be at a risk of developing post-transplant diabetes and malignancies. So that was sort of like covering up the genetic testing in recipients, but more importantly, how does it incorporate into the live donor sort of situation? And again, the fundamental of live donor is to make sure a nephrectomy is not going to have any negative consequences on an individual in their lifetime. And while we've had excellent outcomes, there are reports that have suggested somewhat of an increased risk in developing end-stage kidney disease, and the rates seem to be higher if there is a familial, if the donor is related to the recipient, suggesting a genetic component. So how can we take genetic testing to better give sort of a prognosis long-term in terms of the outcomes of an individual who's undergone a nephrectomy, especially if there's been family history? Transplant programs are actually required to have some sort of a strategy for conditions like PKD. So, and especially if the disease is unknown, it's sort of incumbent on the transplant program to kind of like assess, some of those things when having the discussion with the donor. So just a couple scenarios. We had a great session earlier today on the African-American ancestry and the impact it has. Over the past 8 or 9 years, we've had excellent reports, and I've put this sort of as a summary slide, and a great paper that I sort of would recommend everybody take a look to kind of assess the impact donation might have on individuals on African-American ancestry. And some of these papers are raising some concerns that there might be an increased risk of CKD and end-stage kidney disease after a living kidney donation. And as a result, there have been some investigators that have been looking into it. This paper that looked at 136 African-American donors and broke it down into high risk because they were homozygous for the EPOL1. They did find lower baseline kidney function to start out with and somewhat of a faster rate of decline in the kidney function. 2 out of the 19 individuals ended up being on dialysis. So it's sort of raising some concerns. And across the board, if you were to talk to transplant centers, and this paper published 2 years ago actually looked at it, and about 50% of the centers were starting to offer the testing to donors. About 4% of them were testing it routinely, 14% case by case, and then most of the centers sort of felt that in the next coming years, there was going to be an increased utilization of the test in African-American donors. And as we heard earlier today, the concern really is shrinking the donor pool, especially in a group that already has smaller numbers to start out with. And while we always worry about do no harm to the donor, we don't factor in the psychological harm it might do to, let's say, a parent who wants to donate to their child and give them the best quality of life and a survival advantage. So, people are really looking into it very closely, and sort of the compromise as of now appears to be that if you have a younger donor who's homozygous, probably not consider them for being donors, but older individuals may proceed with high risk variants. And that summary slide that I showed you, and that most of the data sort of suggested, like if you had an older African American donor, they were less likely as opposed to Caucasian. If there was a higher incidence when we looked back on the individual who had developed end-stage kidney disease. So it might actually be okay for an older individual in this group, so that we don't completely shrink the donor pool. But if you were to ask transplant centers, there is quite a bit of variability that we're kind of going through right now. We heard about the polycystic kidney disease, and I think Dr. Rastogi underscored the importance of how the diagnosis might actually, we may have the wrong diagnosis. And by and large, the imaging is really helpful in the PKD type 1, because if you don't have the cyst by age 30, you can sort of exclude it. But the challenge is many times we have donors between the age of 30 and 40, and we are not really sure, because as we heard, genes can mimic adult polycystic kidney disease. There's some limitations in terms of the imaging. So really, if we are not dealing with a classic ADPKD in a recipient, there should be a lower threshold for doing a genetic testing. This was a paper that sort of tried to integrate imaging with genetic testing. And by and large, what it is really coming to is, like, if the donor, as I mentioned, is between the age of 30 to 40 or less than 40, you would go ahead and try to do a genetic testing on the recipient, see what the mutation was, and then test the donor. Obviously, if they have the same mutation, you wouldn't consider them and would allow them to proceed if they don't. Living donors with thin basement membrane disease and Alports, I can say that genetic testing is really disrupting the classical classifications that we've had in Alports. And a lot of this is because for the longest time, we did not really understand the sort of the inheritance of it. And as we heard, COL4A3 and 4 are like a pathogenic variant that might be present in about 1% of the population, but don't seem to have a significant impact on the renal function. And oftentimes, as transplant centers, we are trying to figure out whether somebody has thin basement membrane disease and Alports. And we were talking how sometimes it's harder to do a kidney biopsy than to do an actual process of the living donation. But this might be a place where we could start out by genetic testing to get a better feel for what a mutation might exist. And again, that has limitations as well. And this paper actually challenges the definition of autosomal dominant Alport syndrome, and sort of suggests that we should call it as sort of a variant that has, COL4A mutation if we detect them, and consistent with thin basement membrane disease. And again, kind of like underscoring how our terminology, I suspect, in the next few years is going to change in some of these things. Two very nice papers, and you kind of heard a reference to this. One, because now we do have genetic testing, and historically we've transplanted people who might have had, family members with Alport. There was this nice case report where the son who had an autosomal recessive Alports, the dad later in life did have some hearing impairment, but had excellent kidney function. The paper goes on to talk about how the son had excellent kidney function, dad had been doing really well, gone into transplant Olympics, but then later in life did develop some hearing issues, and they were able to detect a mutation. Again, sort of confirming that despite the fact that they had a mutation, the dad was still doing well. But again, the sort of limitations that not every diagnosis is completely exclusive and involves. And the second paper, which I found really interesting, basically had a son who had an X-linked Alport syndrome, and the mother who wanted to donate had hematuria since age 10. When they did the mutations, they were not able to find any mutation on her, but they went a step ahead and then actually collected the podocytes in the urine, and then checked the maternal DNA between the peripheral blood, which was negative for any mutation, and that did uncover a COL4A5 mutation in the mother. So as of now, the mother has not donated. The son was pre-transplant. Again, sort of underscoring our evolving understanding of some of these things that have sort of historically been there since Alport called it Alport. Overall, individuals with FSGS, donors with FSGS are always somewhat of a concern for a transplant program. My live donor coordinator is so worried about it because we'd had 2 donors that there was some recurrence into it. But fortunately, we are doing genetic testing. Our understanding of this is evolving as well. The Toronto GN network, which is one of the biggest longitudinal follow-up of individuals, had a paper where they looked up their FSGS cohort. And as you can see over here, a substantial portion of those individuals were again detected with the COL4A a mutation. So again, evolving our understanding of some of these conditions, and it would be reassuring for the family and the patient to kind of like overall know if we kind of lack certain mutations that they may be able to proceed and not really be as a high risk of recurrence. And as we start to think about it, I'm wondering if some of the lack of these, or these mutations do predispose to forming antibodies like we are used to when a bigger gene like the COL4A5 is deleted, and if some of the recurrence. So we're starting to collect all our historic patients that had really miserable outcomes after with the recurrence to kind of go back and see if we can do genetic testing. So, and I have my contact information if there's any individuals that like to collaborate with it, would be absolutely fantastic. 2 other conditions that do create some sort of an discussion point are individuals that have had stones in the past. By and large, a paper kind of looked into it. About 80% of the transplant programs don't have really strict guidelines on preventing individuals, especially if they've just had 1 stone. But as you can see to the right, there are about 30 gene mutations that have now been uncovered in stone formers. So if you have an extremely young donor, the yield of detecting one of these mutations is pretty substantial. So there might be some value in kind of like getting to the exact etiology. So corrective measures can be sort of recommended down the road to prevent any recurrence. So now, just to kind of like summarize what our experience has been with the at USC. So our first patient was tested in May 2020, and it was basically used both in the pre-transplant as well as the post-transplant settings. And the criteria kind of like was based off of what we really saw the literature looking. Again, you saw the studies were from all over the world, from the United States, from Ireland, from China, from Germany. I'm forgetting one country, but it's sort of like across the board, we're looking at this data come out suggestive that like if there's a family history, if there's an atypical presentation, if there was a young individual with ESRD of an unclear etiology, there might be a higher yield to uncover a mutation. So far, we've tested it on 342 individuals, and 60 of them had a positive result, about 18%, kind of like consistent with what we've seen in some of the data. But surprisingly, we had a higher rate of detecting variants of unknown significance of about 90%, and an average age was about 49 years. In our group. And these are sort of like the top 5 diagnoses of what we are seeing. Again, the COL4A seeming to lead the way. Some individuals did actually were homozygous for the EPOL1. And sort of, this is sort of like the summary of all the diagnoses that we have sort of made in these individuals. And just to kind of like show you what sort of clinical implications it has had. So for one patient that was homozygous, we had her daughter wanted to donate, so we kind of tested. The daughter was tested. She was she was not homozygous, so we were able to proceed with the living donation in an African American woman. We had an elderly woman who we found a COL4A5 mutation, and obviously we sent her for ENT opto-eval. We checked for anti-glomerular basement membrane antibodies and kind of informed our referring physician that, just so that, and obviously informed the patient to let other family members know. There was actually another patient with a COL4A that was actually transplanted at UCLA and that had a diagnosis of GN. So one wonders if she had anti-GBM antibody as the cause of her first loss of her first allograft. And then really interestingly, we found a RET mutation in one of her patients, and then on further questioning, found out that she had a maternal aunt with a thyroid cancer at our county hospital. And then we referred her over to our endocrine folks to rule out multiple endocrine neoplasia syndrome. Again, with immunosuppression, who knows whether she would have been at a higher risk of some of these malignancies. The fact that we were able to incorporate some of this decision-making was really good. Now, even on our variants of unknown significance, it has opened up our eyes to things that we may not have known. Like for cystinosis, I have now been sending out white blood cell cysteine levels, working with UCSD. It has opened up relationships with a company that does it in terms of like trying to find out, to challenge some of what we have sort of just assumed, like, where the white blood cell cysteine level, does it get impacted by immunosuppression if you have low white blood cell count? So these are things that their scientific liaison hasn't been able to answer. So we're working on some of these things and collecting data. Patient with oxaluria that we had, again, it was a type 2 oxaluria, but then I informed the pathologist about it, and we were able to find a calcium oxalate crystal inside the allograft biopsy. We had an individual with familial Mediterranean fever that is being looked into amyloid because it sort of led on to some sort of cardiomyopathy, and then an individual with mitochondrial dysfunction. And as we know, sometimes we check for carnitine levels in patients. So just to kind of like, it has really opened up beyond what we've conventionally looked, in terms of what else can be done in terms of improving some of these outcomes. This is still in works, but the LUZ algorithm that we have, a recipient, if they are pre-transplant, if they get tested and we find a mutation, through our organ transplant tracking record, through our Otter, we are trying to put up a clinical alert so that the donor can then be, when the donor is tested, we can incorporate that into it, as well as if they've not been transplanted themselves, to put it in the post-transplant assessment as well. A hard copy is provided to the patient, especially if there is a familial component that we want folks to pass the information on, and obviously there is there is a contact information to the genetic counselor in case the patient or the family wanted to explore this further. So to summarize, I just want to sort of suggest that the overall, of course, the phenotype is a combination of the genotype and the environment. And I'm in Hollywood, so I'm going to let Arnold Schwarzenegger from the Twins movie explain the situation when he's trying to tell Danny DeVito, like, we're twins, we're basically same. And Danny DeVito is having none of it. He's like, so if we're alike, then why are we so God bleep different? And he goes, well, don't forget, I was taken to a beautiful island. I was cared for, loved, and you had nobody. So the bottom line is, like, we're entering this phase where we really do have to incorporate all these things together. And I'm hoping we're entering there's a shift in the paradigm. We're entering an era where the genetic data does get incorporated into the clinical, the morphological, and the pathophysiological understanding, so we can incorporate the eventual goal of medicine, which is personalized patient management, both in nephrology and transplant nephrology. Thank you very much. I just wanted to leave my contact information over here for folks, and I also want to thank Natera for helping with the data. Thank you very much. I really appreciate it.
Thank you, Dr. Kazi.
Thank you, Dr. Rastogi.
Thank you very much. That was actually an excellent presentation on the role of gene testing in transplant, both pre and post, but also for living donors. And I think the other point that I just want to reinforce that Dr. Kazi mentioned is getting the right diagnosis. This is very, very important. And I think Dr. Wang went over this as well, in which he mentioned that the retesting or actually correcting the diagnosis is actually important. So anyways, with this, we are getting to the next section. And it's really my privilege, my honor to introduce my next speaker, the guest of honor for today. Her name is Miss Alex Schwartz. She's a medical social worker by training and practice, and a leadership and organizational culture expert and mental health activist, which, in general is very important. We have always focused on psychology, psychotherapy and psychology, but in this day and age of COVID-19, this is actually even more important. And she really fights to promote positive mental health and well-being. So a real advocate of overall wellness. She's a graduate of USC School of Social Work. She combines her training in social work and positive psychology to act as a patient advocate. And she's a great one. She's actually a member of the Circle of CORE that I had mentioned, the patient support and advocacy group, and supporting patients and their families. So we should never forget the families. And you'll hear her story a bit more when she goes into her parents as well. Her approach is holistic, evidence-based, and grounded in past experience, including her own mental and physical health journey with cystic kidney disease. She's currently a patient at the Core Kidney Program at UCLA, and her passion is to better the lives of others by whatever she can do. And she has done so much. And she has actually written a book, a children's book, A Bright House. And if you don't have it, please go and buy it. I think it's on Amazon. I have a copy of that, signed by Alex herself. So Alex is inspired by her own journey to spread the message of the need for patient care through education, research, advocacy, and hope. So Alex, it's a real pleasure and honor and privilege.
Thank you.
Thank you so much for joining us. Much, much appreciated.
Thank you so much for having me. Hi, everybody. My name is Alex Schwartz. I'm so excited to be here today. I've always imagined this day happening, but I never imagined it actually happening. I get to stand in front of or amongst the most influential people that have created and made a huge impact in my life. And that's really important to me, and I'll go into that in a couple of minutes. But part of being a patient in the CORE program and just going through the hardships and the challenges of this disease, what it is, what it looks like, how it feels, we always have to remember the support system that stands behind us. So I'm not in this alone. My doctors are in this with me, but the most important other factor that's in this with me is my family. So today, I wanted to start off by just saying how grateful I am to be here with all of you guys, amongst the most influential doctors that have impacted my life incredibly, as well as my parents. This morning, I get to introduce my parents, Annie and Robert, and I get to share the stage with them. So I wanted to invite them up to kind of start the journey for you guys, where it all started, when it happened, and then we'll finish off with how it's going and how we've kind of maneuvered through it.
Well, that was great, Alex. I think that one of the things that is so impactful for all of us is being able to be here listening to all of you today. I have never been around so many doctors really in this whole journey with Alex that have such a dedication for finding what this disease is. And there are so many aspects of it. It's almost like, it's obviously, I don't understand any of it, but I know you're all doing a really good job. So I'm very grateful for that. The story with Alex starts when I actually got pregnant, and we had a pretty great pregnancy. I was thrilled because my first one, it seemed, was very, very long. And I when I got pregnant with Alex, everything seemed really fine. And my doctor had me come in for an ultrasound. This was 30 years ago. And I was excited for this ultrasound because I thought, wow, it's really innovative and we're going to see this baby. And I'm so excited. And the doctor that I was seeing is still my doctor. And he's amazing. His name is Dr. Don Nishiguchi. And I was so thrilled that he had this equipment in his office. So I just had to go to his office and he started to conduct the ultrasound. Robert was there. And as he was doing it, he was showing us all the different things about Alex. And we really couldn't see that much. But somehow or another, he was able to see on her little kidneys that there was something going on. And at that point, the day and the conversation got a little bit more serious. And he said, I'm sure everything's going to be fine, but I want to do a little bit more investigation. And he told us for me to kind of, take it easy. We only had about 2.5, 3 months to go. And we were going to go down to Cedars to have some testing done. And so that all seemed fine. And, we went along. And then the day came that I had Alex. It was a C-section. So I got to have my nails and hair and toes done. And I was very happy about that. And we went in and, scheduled and everything went as planned. And what I didn't know was what was happening behind the scenes is what Robert will explain.
Well, our doctor, actually, I didn't know that he had a nephrologist that was kind of in the shadows that we had no idea was hanging around the hospital for Alex to come out so the nephrologist can see Alex right away. And when my wife was under all those lovely drugs that made her all happy, and the doctor came to us, Alex came out, we waited a while, then this nephrologist came out and said, this is rough, guys. The nephrologist said, please don't get attached to your daughter. She might not have a year to live. And my mom was with me at that time. And my mom said, that's unacceptable. And my mom is a retired administrator at USC. And she started going through her contacts of so many years through the USC. And she just got on the phone. She was on the phone all day long. And at that point, that led us to a USC doctor at Children's Hospital. And from that point, I'll let my wife, take the story. But before I say that, I gotta, I don't have much to say except this is really a family. When you find out your child has something, it doesn't stop right there. It's a day-to-day living with this that my daughter's an overachiever. She's beautiful. She's smart. And, she lived the life of we all want to live, and to find out, when does it end? How does it work? And we had all these questions that no doctors have ever been able to give us solid answers on until actually, and I want to thank Natera because we found out our answers 30 years after we didn't understand this whole thing through the genetic testing. We found out what she actually has, which to me doesn't stop anything, but it gives me as the dad, as a parent, peace of mind to know that we have a starting point and now we know how to go from that starting point forward for whatever we have to do for her life. So this genetic testing is big, so I want to thank him for that.
Well, and we want to thank Dr. Rastogi and the Kidney Core program for veering us in that direction to be able to go that extra step. And I know Alex will go into that later. What happened next really quickly is that four days after I had my C-section, we had an appointment at the Children's Hospital in Los Angeles with the head nephrologist. And I remember Robert and I wheeling Alex in her little, crib, whatever. And we were going through Children's Hospital and we were just thanking God that all she had was a kidney disease, because we saw incredible things there. But the good news was that this nephrologist was amazing. She had been there for many years. And she took a look at Alex and she said, my goodness, Alex is a very healthy child. She looks amazing. She said, you know what? Don't watch TV. Don't go on the internet, whatever that was. Don't go searching out information. She said, one of the things I like to do is I just like to look at my patients, and these are the things I look for. So I'm going to give you a list of stuff to look for. And if she's growing and she's doing well, you're in good shape. And she said, and I don't know exactly what this is, but we're going to do a biopsy when she's 7 months old. So we came back to Children's Hospital when she was 7 months old. She was growing normally. Nothing was wrong. And she had a biopsy. She did very well. We were home the next day almost. And we got the results that she had a glomerular cystic kidney disease. The doctor told us that it was very rare. She had only seen it in her practice 4 times. She said that, and I asked the question, what can I do for a preventative? What can I do to slow the progression? What can I do as a parent with her food and whatever? And she said, there's nothing really to do. Just watch her growth and development, look for certain signs. You'll know when she goes into renal failure. And at that point, we'll do our job. So all along the journey with Alex, every year we would go in for blood work and urine and blood work and urine and then ultrasounds. And, we didn't see a huge progression in terms of what the doctors were telling us. And they never asked to do any other kind of testing. They were satisfied with the ultrasound. They were satisfied with the blood and urine. And so we just sort of went along with it. We didn't feel like we were in any kind of danger. And so she was living a very healthy life. She was playing soccer. She was the captain of the cheerleading team, and leading a very healthy life, eating the way she wanted, drinking the way she wanted, and of course then got into college and moved to Santa Barbara. And at that point, we were sort of not involved in that much more in her health, and it seemed as if things were going along well. And so I just also want to reiterate in this story that, Robert and I were blessed because we have really good health insurance. We felt like we were doing everything we could possibly do to make sure Alex was as healthy and happy as she could possibly be. There was never any indication that something was coming because, the doctor had...
We always knew it was coming, though.
We knew something was coming, but we just didn't know when it was coming. And so as long as she was healthy and happy and there were no real changes, we seemed fine. And it's also, you kind of get in this relaxed mode of health care, right? Where, nothing's going wrong. The blood work seems okay. No one says anything. And you're sort of going through well, who knows? Maybe she's going to be okay. Maybe this is all good. So anyway, then you went off to college. And I'll just leave it there.
That's our story.
That's our story. I feel incredibly overwhelmed. I didn't anticipate as many tears in the very beginning as we had, but I think it really sheds light on how powerful this has been for us. And, in the beginning of all of this, I was living an incredibly healthy life. My journey was so fun. I was able to travel the world, and I was a gymnast, and I was captain of the cheer team. And life was fun. It was easy. And then I went off to college, and everything was fine. I ended up slipping into a dark place. I met a woman on an airplane, and she changed my life forever. That very next day, I ended up signing up for this program, which was the Positive Psychology Certification Program. And why do I bring this up? I'll share in a couple of minutes. That program changed my life. So I didn't have any of this information regarding my disease at that time. I was just in a hard place. I hit rock bottom, and I needed a little bit of hope to get me to the next chapter. The Positive Psychology Program lent me the tools that today I'm able to use that help promote and push positivity and hope to others that are in need. So that'll be important in a couple of minutes, but I'll never forget, feels like yesterday. I was starting my graduate program at USC at the School of Social Work in 2016. And I felt a little tickle in my throat when finals were coming along my very first semester. And I had never endured what it was like to have finals in a graduate program. Well, at that moment, I endured it and I was like, I got to hit the doctor. So I went home to my family practitioner and out of nowhere, he was like, have you seen a nephrologist? And I said, no, I haven't seen my nephrologist. Actually, I don't remember the last time I saw my nephrologist. And he's like, well, you should probably go see your nephrologist. And I said, okay, is there a problem? Is there something that I need to be? Because I'm just here because I just have a tickle. And he said, well, you're in 3rd stage CKD. And I said, what does that mean? And he's like, well, you should probably go see your nephrologist. And I remember it like it was yesterday. I left there bawling. I ran to my dad's office. I said, oh my gosh, I don't know what to do. I was just given this information. What do we do with it? How do we move forward? Where should I go? And initially, we both thought, well, you're at USC, so you have a nice segue. I was on their insurance at the time. And so it was an automatic into Keck School of Medicine. So I found a doctor at USC and I started the process. And could you imagine, right? You've lived, at that point, I was 26 years old. You've lived 26 years of bliss. Nothing's been wrong. You've stayed, on top of getting your urine test and your blood test and all the things that the doctors want you to get, right? And mind you, it starts with this much and then it goes to this much, what the doctors want. So 26 years later, I'm getting all of these weird things happening to me. And as I'm sharing them with the doctors, this specific doctor was like, okay, well, we need to take you off the supplement and you should be good. Let's see if you feel a difference. And I said, okay, well, do I need to get a nutritionist? I was the one asking the questions. I found out in that very moment that nobody else was going to be an advocate for me. I had to be an advocate for myself. I had to step into the position of uncertainty and fear to make sure that I had all the questions answered so that I could make the next move and the right move in that matter. So I wasn't getting the answers that I needed from this specific doctor. And every time I went in, it just felt odd. I would walk in, it had to be on a specific day, had to be at a specific time, and within 20 minutes, you were out the door. I didn't go off and see another doctor. I didn't get an opportunity to even wonder if there was another doctor out there to see or to speak to. And it was at that point that I was like, this isn't gonna work for me. I had to make that decision because nobody else was gonna make it for me. I was unhappy, I was unmotivated, I wasn't disciplined around this genetic disease or this disease at the time. And I didn't know where to go from there. So again, imagine your whole life, you're living in this uncertainty. Never really was a big deal. Now it's a massive deal. Okay, I'm only in 3rd stage. How long does it take to progress to 4th stage? What happens after 4th stage? I mean, I'm a perfectionist, I'm an overachiever. You could imagine the type of things that were going through my mind. It was a lot, and it was extremely overwhelming. It was just as overwhelming as sitting in this room this morning and pacing back and forth, listening to all these incredible doctors share about the most fascinating cases. And I'm sitting in the back asking my brain is just wiring off all of these crazy questions. Well, what if this happens to me? What's going to happen? Who do I need to speak to? Oh my gosh, is this going to be me in 5 years? Is it in my family? Is it in their genes? I don't know. We still don't have those answers. Anyways, it's a lot. And my mom ends up coming home one day and lets me know that she has a good friend that she plays tennis with. And it just so happens to be a patient of Dr. Rastogi's. And she was like, I'm just gonna try and, share your name and what you have. And I said, perfect, whatever you need, share anything you want, doesn't matter. And at the time, you guys, I was in a really dark place. I couldn't find a doctor that was useful or helpful to me. I was trying to maneuver through all of these obstacles. I didn't know if I was supposed to be eating certain things, if I was supposed to drop certain foods, not be drinking. So I said, anybody, I was putting out into the universe, anybody come in and help me because I'm really eager. I'm really eager to jump both feet in and really take this on because I knew that nobody else was going to make that happen except for me. I wanted to make sure I was ready to walk into that fire and say, it's not me that's going to fail my body is going to fail me. And it just so happened that a miracle came into the palm of my lap when this woman came back to my mom and said, you should just email Dr. Rastogi's team and let's see what we can do. And I said, okay, I'll email. It didn't take one email. It didn't take 2 emails. It took nearly 6 emails to get in contact with his team to then find out that the day the world went into quarantine was the day I got in to see Dr. Rastogi. And that tears me up a lot because, you know, at that point it had been 29 years of trying to figure all of this out and just feeling alone. Not trying to put the pressure on my family, even though they're my support system, but I'm an adult. I can make these decisions. I should know. I should know what to do. I should know what's right. And when I had my first conversation with Dr. Rastogi, one of my biggest fears was really around the pandemic and how COVID-19 could affect me and, you know, what did I need to do? And the first thing that he told me was, don't let this pandemic come between you and living your best life. And I took that and I soared with it. And so why did I bring up the whole positive psychology movement? The tools that I learned in that program helped me maneuver through the hardships and obstacles and the challenge of what this disease is, what it was, the questions of it, feeling alone, being uncertain in specific areas. I'm so grateful for my experience in the positive psychology world because I wouldn't be who I am without that. But on the other hand, I'm so even more grateful for Dr. Rastogi and his team and the team that's here today because the second thing that he said to me and the only thing that any doctor has ever said to me is, you know, maybe we should just get you a genetic test. And I mean, I think I can say for all 3 of us, we were like, what's a genetic test? And he was like, I have this great doctor. Her name is Dr. Bianca Russell, and she's here, and she knows how I feel, and I get emotional because it's like, man, it took 29 years for one doctor to look at me and say, let's just take a genetic test. It could be as simple as that. However, there's a big chance that it's going to come up unknown, that we're not going to know what it is. And I said, well, I'm willing to take the risk. Oh man, remember the day? I think I overheard yesterday at dinner and Bianca was like, the day that we found out, I picked up the phone and called Dr. Rastogi and was like, I found it. It came up. And that day that we found out, you know, you could imagine living 29 years with a cystic disease to then finding out that you have HNF1 beta, which is a genetic disease that was spoken about briefly today. And to me, again, the overwhelmingness of being here and hearing about all of that has made me question so much more. But in light of that, I can kind of break it down for you from a patient standpoint and point of view. What ends up happening with this one genetic disease, at least the way that I kind of put it together in my head, is there's all these things that fall under it. Things like being predisposed to diabetes, kidney cystic disease, gout, you know, all these areas that I had never thought about, but yet were happening to me. So I had a random flare-up. We thought it was something else, ended up being a gout flare-up. I was really, you know, I would feel really lethargic and tired at times, and my blood sugar would get really low. Could have potentially been, a feeling around being pre-diabetic. All of these things started answering questions that I've lived with a long time. The uncertainties became more certain. I started finding understanding and the value behind why this was happening and what types of questions I should be asking to doctors so that it could make more of an impact long-term for me. So with all of that knowledge, I went back to Dr. Rastogi and I said, okay, so we have the answer. This is the HNF1 beta, great. Now, here's the other things, the bigger questions that I have. What about pregnancy and having a child? And what about being pre-diabetic? How is that going to affect me long term? And I started saying, Dr. Rastogi, I need to see all of these doctors. I know we're in a pandemic, but I need to see them now. And within a week, he got me on the phone. Everyone's office was calling me. And mind you guys, we were on pure lockdown. There wasn't anybody going into the hospitals. And yeah, within actually, I think it was 48 hours, I had my first phone call. And that was from Dr. Bianca Russell. And then after that, it was for the doctor endocrinologist. And then after that, it was the high risk OB. And then after that, and for the first time in 29 years, as a patient, I felt seen. I felt heard. I felt a part of the answer, trying to find the answer. And for the first time, I felt, like I had shared just a couple minutes ago, that all these people are investing so much time into me that it was my job to invest that time into myself too. And so what came from this? At that point, I decided to go 100% vegan, which has been a nightmare, if I could be really honest with you. It's been a nightmare, but it's been the most incredible experience. I always tell people, I love to tell them, no, I don't wish upon anybody to become vegan. However, what being vegan has allowed me to do is so much more. I mean, besides the fact that it helps you sleep better, you're more clear, you have more clarity. It's a nightmare to talk about with people because they're more, trying to figure out where we can eat, and I'm more trying to figure out where we can eat for them. But what it really did for me was the idea behind being vegan is that for especially with cystic diseases, is that it's easier to break down vegan foods, right? It's plants, so it's a lot easier. And what we saw in the past 18 months while I've been a patient with Dr. Rastogi is instrumental results. I mean, mind-blowing results, actually, especially from my previous test that was just on about a week ago. I started way down here with my GFR in the early, beginning 30s. About 18 months later, I'm at a GFR of 54. And the question to me at that point became, how do you get from 30 to 54? I made the choice to make these instrumental changes that have made a huge impact in my life. Going vegan, not drinking for about 18 months, working out once a day instead of working out 3 times a day like I was doing in quarantine, which actually was becoming more of a detriment to my life than it was allowing me to push forward and be successful and flourish. And just being a lot happier. I changed my scenery. I moved to San Diego. I started a new job, new life out there. And now the journey is so much different for me. It's empowering, right? It's allowed me not only to be on stage here and get to share the stage with my parents, which I never thought would ever happen, but it's allowed me to not only share, but also empower others to use their voice, to bring up their concerns, to be at the forefront of their own lives, to ask the right questions. Patient advocacy, there isn't enough of it. And that's one thing that, as I stand on this stage today, that I want to see more of. We always are going to need more of clinical research. We're always going to need more of psychologists and clinical researchers and doctors. But the one thing that I don't see enough of, and even as a social worker, is patient advocacy and patient support. It was this Natera that this was the first time I've ever heard what a genetic counselor was. The folks who call you after you've been diagnosed with something beyond what it was, what the original diagnosis was. and to kind of take you through all the stuff and get you ready for the family planning of what's to come. As a patient advocate and a patient support system, myself, and doing that with my career, you need something beyond that. A genetic counselor has all these patients, they invest all this time to making sure that you have the knowledge, and now you need an advocate to come in and help you through that process. So I stand before you today so grateful that I got the opportunity to share my story with you guys. You know, it's been, I keep saying it's been so overwhelming to be in a room with some of the brightest minds. And then also for the first time getting to share the stage with my parents, which was quite emotional. And, you know, I can't say enough to the doctors on how much time and effort they've put into me and my life. But even more so, I just want to thank you guys. Okay. For just all of the support, for all the support. I know that it's been really hard.
It's good. You're a good patient.
And challenging, but we're getting through it, and together we're advocating for others. And so yes. I appreciate you guys all listening to my story and our story. And, you know, if there's one last thing that I could say is just be the hope for somebody, because here. Because just a little bit of hope can inspire and can help somebody smile again. So thank you all for being that hope for us. We really appreciate it. Thank you.
Thank you, Dr. Rastogi, for everything.
Thank you.
Thank you. Really appreciate you.
Thank you. Whoa, what a powerful story. Just a couple of comments I want to make. I've never heard Robert speak so much. We call him the first few visits that I had with Alex, video visits, I could only see a hand. So that's great. Thank you. And so just a couple of points that I want to bring out from Alex's story. One of the importance of testing, right? Getting the right diagnosis. She has what we call HNF1, hepatic nuclear factor 1 beta mutation, and that affects organs besides the kidneys, whether it be predisposing diabetes, gout, liver issues, anatomical problems. And that's where I think the role of a nephrologist becomes key. It's not just taking care of the kidneys, but also making the right referrals. And I think we did that right away. And I think we should not miss that point. We know about ADPKD. They can have brain aneurysms. They can have liver. We know about L-port, eyes and ears. But there are other genetic diseases that you can diagnose and make the right referrals to make it smoother. So that's one part that I think is very powerful and very important. But the second part is the patient and their family themselves. And, Alex ran with she was eager, she was hungry. She's a social worker. She believes in mental health. And she did everything that she was asked to do. And her kidney function has improved significantly. She still has a mutation. The best we can do is to slow down. We don't have any drug that treats this mutation, but she's doing everything that she can. And she's an inspiration to all of us. And I'm sure all of us had tears in their eyes when they heard her story. So I want to thank Alex. I want to thank her parents for being here and sharing their story. So thank you very much. Now we'll go back to some Q&A. I'm not sure how much time I've left, but I'll try to cover some of the questions that came in. So Marina, I'll start with you, our genetic counselor. How do we counsel and facilitate family testing to identify at-risk family members?
Sometimes it's as easy as give your patient a letter that they can distribute with some information, because they can be a little bit self-conscious in explaining what's going on in the family to other family members. But sometimes it's more complex than that, where you have to think about your patient and your patient's family as a social network and try to find out, okay, well, what member in your family is really good at gathering health information from everyone, or which family member is really great at disseminating information, right? So that's the disseminator. And is Uncle Bob going to be a blocker? So he's going to withhold genetic information, and therefore his side of the family is never going to know. So help your family understand their dynamics, and see if there's anything you could do to help navigate that.
Yeah, well, I try to do that, but I don't have the charm that Marina has. So I think that also we need to put in the mix. So thank you, Marina. Now, Dr. Russell, this question is for you. We have a robust genetics department within our institution, but how do we facilitate coordination of care with our genetic colleagues?
I think the first question is to ask. The field of renal genetics is really exploding. And as you've heard today from all of our speakers, there's so many different parts to it and so many moving pieces. And I think genetics as a field has a lot of subspecialties within it, and a lot of people have interest in different parts of the field of genetics, but you never know until you ask. And that's exactly what Dr. Rastogi did. Recruited me as a new faculty and said, hey, are you interested in the kidneys? And I said, sure. And we started a collaboration that's really grown. So it never hurts to ask. And Marina has been an amazing collaborator for me and has really taken on a lot of these renal nephrology patients and seeing them as genetic counseling only visits as well. So there is really a nice opportunity, I think, to collaborate with a geneticist, but also a genetic counselor, and get creative about ways to work together, and keeping that line of communication open is really important. So the first step is just to ask and see if you can get someone inspired and interested.
Great. Thank you. Thank you, Dr. Russell. And, we are so grateful. And for all the faculty here, especially the two of you at UCLA Health, has made such a big difference, and Dr. Wang. So thank you. Thank you so much. And talking about Dr. Wang, the next question is for you, Dr. Wang. As a pediatric nephrologist, can you comment on the importance of family counseling after a child's diagnosis, specifically counseling for family planning for future children?
Yes, that's a great question. It's very important. We work closely with our genetics colleagues and the genetic counselors in our institution, but it really is a multidisciplinary field where after diagnosis, there not just for the extrarenal manifestations that can occur based on the diagnosis, but it's important for the family to really understand what is going on, the implications for family planning, for their future fertility, and it's really a team effort. It's important to get the kids diagnosed as early as possible, and it's really great that we have all these genetic tests that are now readily available to us. But right with the diagnosis, and even before the genetic test is actually done, I really recommend that all nephrologists and physicians have the geneticist involved and the genetics counselor involved initially at the outset before you kind of get too deep into it.
Very good. And I think that goes back to teamwork and getting the right team. And it takes time to build a team. And we have that now at UCLA at least, and I'm sure we have at USC and UCSF as well. So Dr. Park, I think the next question is for you. How to counsel patients who are 18 years and younger with ADPKD or PKD in general?
Yeah, so as an adult nephrologist, I do not see patients who are under the age of 18, but I often have patients who have children who fall into that age category, or who may have children who are adult children, in the ages of early 20s, which is a different scenario. For individuals who have children under the age of 18, we generally do not recommend universal genetic testing for the sake of a diagnosis alone, simply because the diagnosis could be distressing, and there are no current management strategies that are specifically approved for individuals less than age 18. That said, understanding this diagnosis and keeping an eye out for health symptoms, including high blood pressure or kidney infections, blood in the urine, et cetera, are all really important reasons to have the children under the age of 18 of these affected patients to be monitored carefully. As in my first case that I presented today, the diagnosis of the patient's young daughter actually happened relatively soon after her own diagnosis and was not sought out specifically, but happened to be coincidental because of other symptoms her daughter was having. So, certainly children under the age of 18 are diagnosed with autosomal dominant polycystic kidney disease, but use of genetic testing to make that diagnosis is not something that is recommended.
Great. Thank you.
And
Thank you so
can
much.
I add an
Absolutely.
exception too is for prenatal purposes. So that's sort of the one asterisk next to it all that.
Totally. Thank you so much for saying that. And indeed, we do have, as we alluded to, in our institutions, we're lucky to have a team approach. So for sure, at our institution with genetic counseling support, genetic support, and with reproductive endocrine, we sometimes do pursue counseling about offspring for individuals whose children are not yet born / are not yet conceived. So I thank you so much for pointing that out, Dr. Russell.
Yeah. And thank you, Dr. Park, and thank you for leading this at UCSF, the Nephro-Genetics, and very much appreciated, and the collaboration between the two programs. Dr. Kazi, the next question is for you. And I think you did touch upon this in your presentation, but it came up again. The testing in potential living kidney donors. If you can just elaborate more on that.
Yes. So basically, what it really comes down to is after a thorough evaluation of the recipient, if we identify any particular etiology that might have an implication on the donor, we start out by doing an assessment of the genetic testing on the recipient, and then factor in the potential that might have in terms of inheritance, obviously if they are related. And again, it's not one particular, because the diseases are different, inheritance is different. We factor those in, but it's sort of like, and again, it's an evolving, as I showed you, most of the papers are just from 2 years ago or 3 years ago, at least in the transplant literature. So it's an evolution that we're trying to incorporate the best strategies on how best to do it for not just the living donor, but oftentimes an individual may not have received a transplant yet. It's part of the pre-transplant screening. But I do want to mention that it does happen when you find a diagnosis, whether it's just PKD, then oftentimes when I go back and ask them some additional history, they find out, oh yeah, my son did have. So then I print out, I have like printed out extra copies so they can, okay, give this to your son's nephrologist, so they can at least trigger off and some sort of a mechanism, because you do kind of feel some sort of there's somebody out there that does not have a diagnosis. So I've like actually printed out multiple hard copies oftentimes to like give it to the recipient. But the bottom line is you sort of incorporate what the diagnosis is initially. Now, sometimes it does become challenging when it's a paired exchange program, and we don't know some of the thing and the logistics of that. But by and large, to keep it simple, it starts out by the recipient workers, and then a domino from that based on what we see in the final report.
No, thank you so much. And I'll also share my experience with living kidney donation, and I was a medical director for 15 years for the living donor program. And one of the challenges that really came up, you spoke about hematuria, you spoke about Alport, you spoke about, but if you look at the chances of a living donor after proper evaluation ending up on dialysis themselves is very minimal, but it's not zero, right? And if you look at the people who do need transplant themselves, majority of them actually have some family history. So I think, and the reason why I bring this up, I think Marina spoke about this, how to, there's a way to bring this out, right? I mean, just telling them we have to get tested is not, but why it's important. I use the word charm, but it's important that, you're smiling, the way you bring this up, and it's not a serious, death sentence you're getting. But who do we test? The short answer could be you test almost everybody. We have 400 genes we can test for, but who would be the low-hanging fruits? And the low-hanging fruits would be patients that we don't know the diagnosis. And hypertension is not a diagnosis, and in a lot of patients, diabetes is not a diagnosis. And this is important because this can have, like you said, Dr. Kazi, in your presentation, very nicely, it could have implication on the recurrence of the disease. And I can share some examples that we had. But also if they have a living donor, and most of them are related still, right? So I think not putting them at risk, but in the right setting, counseling, those are very important. So I think that's very important from my perspective, to make sure that living donors.
You're absolutely right. I mean, nobody wants to reduce the numbers of
No,
living donors.
no,
What we
yeah.
want to reduce is bring it as close to zero. It's like
Right.
you mentioned, the risk is
Right.
not zero, but what
Right.
can we do
Right.
to reduce the risk,
Right.
even further? And
Yeah.
not doing nothing without knowing it is not, because, as we know, the long-term follow-up is starting to evolve. It wasn't until a few years ago we were mandating
Yep.
long-term lab checks
Yeah.
of donors. So we
Yeah.
really don't really know the true burden of what has happened to donors who have
Yes.
donated 40, 50 years ago.
Yep.
And we keep improving, reducing those, chances, incidence, prevalence of anybody that has ever donated to get a kidney,
Right.
have to go back and require a kidney transplant. I have at least 2 patients that have ended up like that. They weren't transplanted at my institution, but these were donors who donated and now have either
They're
received
covered.
a transplant or are on dialysis.
Yeah, and I think that's very, very important, because the other point that I do want to mention is, where does this testing fit in your algorithm, right? That's a question that always comes up. We are people who know about genetics. We specialize in this. We will test. When Alex came to me, the first thing I said, I don't know what glomerulocystic disease is, to be honest with you. It's just a bucket diagnosis, and let's do at least another testing. But we also have to pivot. We do go for kidney biopsies, right? I mean, so can we add a test prior to that? Because expense is, if it's not expensive, it's accessible, then can it fit into the algorithm? And I think that's one message that I would like people to take from this today is that where does this fit into the overall algorithm? And we always talk about cost, we talk about accessibility, how to read the test, but please do think about that. Would this fit into your algorithm? Especially if you don't know the cause, whether it be transplant, dialysis, CKD, does not matter. So thank you, Dr. Kazi, and thank you, everybody else. The next question, I think, is for me. What does the green ribbon stand for? I think everybody has a green ribbon. Alex, you want to take a crack on that before I ask you some more questions?
For kidney awareness.
Okay, very good. Pink ribbon, I tend to fly American Airlines, and they would have those napkins, and all that they have is a pink ribbon. They won't even say what this is for. And we think about pink ribbon as breast cancer. Kidney disease has mortality higher than some of the most common cancers, but we don't think about kidney disease because it's silent. You heard Alex's story that she was asymptomatic, and then she got a scratch. She went. So we have to keep that in mind. So green ribbon campaign. UCLA was one of the few centers that started that, along with UCSF and probably USC as well. Right, Dr. Kazi?
Yes.
Yes. Okay. You have a green ribbon too. So it's about kidney disease awareness. My last few questions are for Alex. First of all, Alex, thank you for sharing your story. It takes a lot of courage to do that, what you did. And you're an amazing speaker and an inspirer. I mean, I just even got some texts from people, my colleagues who were on, and they said, they had tears and they're inspired. But I know we're a bit over time. I'm sorry.
I said thank you for letting me.
And your parents. So these questions are for you, Alex. Can you expand on your lifestyle and the changes that you made? Because I think your GFR went up significantly.
Yeah. So one of the things that I didn't share was when all of this happened, the one question that kept coming to my mind was, what would happen if I woke up every single day and I asked myself, how am I going to show up for myself today? And I wrote down in the beginning of this all of the things that I needed to change in my lifestyle in order for me to show up at 100%, knowing that I wasn't feeling 100%. So just to expand on a couple of those, I knew that it was important, especially during quarantine, to get outside. Even though nobody wanted to be outside, I knew it was important for me to at least get outside for a walk to clear my mind. I was feeling I was overburdened with information that I was reading online and that I was getting from all my doctors, and I didn't really know what to do with it all. My poor parents were going through it as well. So I got outside. The other thing was I went vegan. So when I say that it was awful, it's because going vegan is not easy. Luckily for me, I had gotten off red meat about 3 years prior. So it was really the transition between chicken and fish, kind of getting off chicken and fish. And as back in the day, I used to lift heavy weights. You wouldn't think, but I did, and I loved it. And it was finding the balance between exercising like that and lifting heavy and supplementing your body with the proper amount of food, right? Nourishing your body with what you needed. So that was the biggest thing that I went through was trying to find understanding in all of that. And I didn't do a very good job, I have to be honest. And at times it felt like I was even harder on myself because I didn't understand. But, you know, I just kept saying to myself, this is the process, Alex. I would talk to my doctors and ask the questions, what is it that I need to be eating more of? I did my own research. I went and worked with DaVita a little bit to get some menu items. And you know, and those were the ways that I was showing up for myself. The other one was, which is a sad one, but a great one, is I stopped drinking. The question wasn't whether I should stop drinking or not. The question was, what would happen if I stopped drinking? Would I feel better? And I felt better. And so I was just, instead of being hard on myself and saying, I can't do this, I won't do this, I have to do it this way, I was posing it as, let's just try this. Let me pilot it. You know, so I decided to go vegan. It ended up being instrumental for me. I decided to stop drinking. A lot of people asked why. It was an opportunity to share my story. It was an opportunity to just focus on the unknowns or the things that people just don't know and they don't ask. So I took something that was extremely overwhelming and challenging and I made it an opportunity for growth for not only myself, but for others. So that's kind of how that lifestyle changed and what came from it.
And also it takes discipline.
Yeah.
We were at a fundraiser a few weeks ago, and name is not taken. And there was no vegan food there.
Yeah.
And there was excellent food, but it wasn't vegan. We asked for vegan. You couldn't get it, but you didn't eat anything. You know, it was so tempting to eat all that stuff, but you didn't. And I was watching you. So there was a lot of discipline over there. Thank you, Alex. There are a couple more questions. There are a lot of comments coming about how inspirational you are and hope you spoke about, right? And that's very important. So this is coming from one of the physicians. How do I empower my patients to take control of their own kidney health? And I think you've already spoken about this, but if you can get just 2 sentences on that, that would be great.
Patient advocacy.
Yeah.
That would be my biggest push. In a very short 30 seconds, sometimes it can be, they're all incredibly smart, and yet one of the differentials is we just don't speak the same language. So if you can bring somebody in that can almost take what you're saying and put it into an easier way of understanding, plus with the story, it's more likely that the patient or the end user is going to latch on and move forward with it. So I would definitely push a patient advocate or somebody that really aligns with what it is that you're trying to have happen, and kind of meet the patient where they're at to hold space for that difficult conversation.
We need more patient advocates. That goes without saying, you know, because I don't have kidney disease. I know about kidney disease and and we need people like you who can share their stories. So last question, and I know we're way over time. How do you, as a patient, know that you have the right doctor?
I tell everybody this. The moment I met Dr. Rastogi, he said to me, everything that we do here at UCLA and in the core program is done with love. And that is how I knew that I was with the right doctor.
Thank you. Thank you, Alex. And Alex, I just want to thank you on behalf of everybody, you and your parents, for coming on a Saturday and sharing your story. It's not easy to share stories, and you should be on a TED Talk. You know, this is. I thought I was at a TED Talk, didn't you? Yeah. So I want to give a round of applause for Alex. Alex, thank you so much. And I want to thank all my esteemed faculty. I learned so much. I'm very, very grateful that you came on a Saturday to share all this stuff. This is all getting recorded. It's going to go on, we'll send you the link, the registrants, but hopefully it's also go on YouTube and social media so everybody can benefit from that. So with that, I want to thank Natera and UCLA Core Kidney Program for putting this together. My esteemed faculty here, thank you very much. And hopefully you found this useful, and we'll meet again soon. Thank you.